Mr. Scott.
Good morning, my lady. Please may we call Professor Charlotte McArdle.
If you can
You can be sworn.
take the Bible in your right hand, repeat after me. I swear by Almighty God
I swear by Almighty God
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Thanks very much.
Good morning, Professor McArdle. Would you please give your full name?
Charlotte McArdle.
And you are the former Chief Nursing Officer of Northern Ireland.
That's correct.
Just like to go through your personal background, which is set out at paragraph 20A of your statement. You are a registered nurse and have been since 1991. You moved to Northern Ireland in 1993, been working in the Belfast Trust, rising up the ranks, and until in 2003 you became Deputy Director of Nursing for the Royal Hospitals Group.
That's correct.
In 2007 you were appointed Director of Nursing, Primary Care and Older People in the South Eastern Health and Social Care Trust.
Correct.
And then you were appointed as Chief Nursing Officer for Northern Ireland on the 5th of April 2013 and remained in post until 31st of October 2021.
Correct.
And you're currently employed at NHS England as Deputy Chief Nursing Officer.
Correct.
You are a visiting professor at the Ulster University, a trustee and vice chair of the Royal College of Nursing Foundation, and a board member of the Faculty of Nursing and Midwifery in the Royal College of Surgeons in Ireland.
Correct.
I'd like to start with your role as CNO in Northern Ireland. You say that you have the lead departmental policy on patient experience, amongst other aspects of your role. How much did your role change when the pandemic started?
It changed quite significantly at the start of the pandemic. I suppose in the early days, we tried to keep everything going as normal, but it became clear relatively quickly that that would not be sustainable. And as the department moved into both its emergency planning plan and we instigated the business continuity plan in the department, a lot of my normal functions in terms of policy, a normal business would have reduced considerably in order to enable me to focus on work on the pandemic, for which I had lead responsibility and for which, as a member of the strategic planning cell, I would have undertaken.
Like a lot of people from Northern Ireland, you speak quite quickly.
Okay.
Can I ask you just to make sure you're not going too fast?
Apologies.
Believe me, I've been caught out by this many times before. So,
I just live in Northern Ireland, so that's it.
just want to talk about some specific features of your role during the pandemic. So you didn't have any operational role in the design or delivery of care to patients, is that right?
No, in the devolved administrations, which is different from the role in England, the Chief Nursing Officer sits in the Department of Health, and its primary function is to advise ministers, senior civil servants and across government on matters that affect nursing and midwifery, and also to lead areas of policy development. So the operational responsibility for the delivery of care sits with the 5 integrated health and social care trusts in Northern Ireland and their executive teams.
So if you're then in the department, did you have any opportunity to be on the front line, as it were, during the pandemic?
Well, as part of my role, I took lead responsibility for the development of the Nightingale hospitals, both facilities, and the reason that I undertook that role primarily was because I had worked in the health service for a considerable period of time and had strong connections with the teams of the 5 health and social care trusts and indeed the wider health system in Northern Ireland. You will understand that Northern Ireland is a small community, and in that small team you are required to do many things, and I would have strong connections and a strong operational experience as being an executive director of nursing, and therefore undertook that role. And in doing so, in taking the lead role for the development of the Nightingale hospitals and a fairly important leadership function on the surge planning element, I was out in the system quite a lot. I visited facilities. I visited the Nightingale facilities with the Minister. I visited other facilities in our health system. I was in touch regularly with frontline nursing staff, and I met daily with the executive directors of nursing and the wider nursing community in Northern Ireland, and often on occasions more than daily. And when it came to the vaccination programme, I undertook shifts in the vaccination team over the Christmas and New Year period when the first vaccination became available.
So you were fairly well plugged into what the experiences were of those who were actually delivering?
Absolutely. And indeed, at the time, 2020 was the year of the Nurse and Midwife global campaign, and in recognition of that, the Minister had agreed to me delivering a leadership programme for nurses and midwives under the age of 35, so they would have been early career nurses. And that programme wasn't able to be developed in the way in which we had planned because of the pandemic, and most of it was online. So I met regularly with that group of nurses who really described for me in detail the changes that they'd had to make in their practice and how they'd had to change location, change rotas, the impact it had on their family, young children, etc. So a lot of that intelligence and information was very much in my thinking in decision making at the department.
So it's fair to say that you were fully aware of all of the concerns of nurses
Yes.
of all ages and all areas of specialty?
I think so.
Sometimes it's not that easy for someone, particularly maybe a junior nurse, to say exactly how they're feeling to the chief nursing officer. Do you think you did receive the unvarnished truth from those who are working?
I mean, I think there's a natural anxiety maybe about, and outside of the pandemic, I would have experienced that in regular visits to organisations and to talk to frontline staff. But because I had done quite a lot of that and had a very strong connection, both with nurses on the front line and through the RCN, the Royal College of Nursing, as an example, I was very familiar with many of the staff who were working in our system, and I was also quite communicative with them through social media. So they had plenty of opportunities to contact me either directly or indirectly to raise their concerns. And indeed, I had representation from ICU nurses on particular issues from that I had met and had spoken to previously, and because they had that connection, they felt able to do so.
Okay. Just want to confirm your responsibility for some areas during the pandemic. It's right that you were responsible for leading the development of visiting guidance
That's
in Northern
correct.
Ireland.
Yes.
That was a role that you were given in the pandemic. It wasn't one that you'd had prior to the pandemic. Is that correct?
Well, we didn't have a national guidance on visiting. That would have been for.
Sorry, just to interrupt. When you say national there,
Sorry, I mean Northern Ireland regional. Each individual organisation would have their own visiting policy. But in the pandemic, both in terms of my communications with directors of nursing, which I said was very frequent, and our collective concern about safety of patients, staff and the population of Northern Ireland, we recognised there needed to be a policy position on visiting because...
I'm going to come back to the specifics of it. It's just at the moment about what your responsibility was and when it was given to you. Just in terms of the infection prevention and control, so it's right that there was a IPC cell set up in Northern Ireland. I think it was called the Regional IPC cell. Is that correct?
That's correct.
And that was been established by the department. Do you remember when that was established?
It was established as part of Gold Command and its structure, so I can't remember exactly the date, but it would have been March time, 2020.
And you weren't a member of that regional IPC cell?
No, I wasn't.
What oversight did you have of that regional IPC cell?
The IPC cell was chaired by the Executive Director of Nursing in the Public Health Agency, and the Public Health Agency in Northern Ireland had responsibility for public health and essentially everything to do with outbreaks, infection, etc. The IPC cell reported through the command structures we had in place at the time. And my oversight was a professional oversight because I'm not an IPC nurse or specialist by background. And my oversight was to support the chair in his role as the chair of the group and to provide professional leadership and support. So effectively, that meant regular communication, usually by telephone, about issues that had arisen, to take a second opinion on things, to seek assurance that the direction of travel was consistent, and to think about any complex challenges that might be for the system and how we might overcome them.
So, given that you didn't have any IPC particular expertise, I think you were just saying, it wouldn't have been your role to review the guidance and point out areas that you thought was wrong. Is that right?
I certainly would have reviewed the guidance, but from a general nursing leadership perspective as opposed to a scientific, specific infection control perspective.
So routes of transmission, for example, would have been completely outside of...
Absolutely. It would
So
be.
when you mentioned, sorry to interrupt, when you mentioned getting a second opinion, what did you mean by that?
So, for example, one of the examples I've provided in my statement is at a point in time, there was an issue raised with the IPC cell in relation to fluid shield masks and a poor fit, and they had come up with kind of interim solutions to overcome that problem until a new mask could be found. And the chair of the IPC cell asked my opinion on that, whether I thought that was a viable option or whether it was something that we could support nurses with. And similarly, when we were trying to outline different pathways and risks, so we had red, high-level risks, amber, medium and low-level green on a traffic light system, the IPC cell produced a draft document which they asked me to look at from an operational sort of management senior nurse perspective, and whether I thought it was feasible or workable, whether the language was correct, whether things were clear. It would be that kind of second opinion role.
The relationship between the regional IPC cell and the UK IPC cell, is that realistically that the UK IPC cell would be providing, obviously there was a Northern Ireland representative on the UK IPC cell, but was it effectively any guidance or direction in the broadest possible sense of the word that came from the UK IPC cell was adopted by the regional IPC cell?
Effectively, a member of the regional IPC cell was at the national cell. The national cell was very much a working group, a consensus group, bringing together experts on the 4 countries. Whatever was decided then at that national cell was taken back to our IPC regional cell for sign-off and agreement, and then the guidance was issued by Public Health England.
But at any point in time, did the regional IPC cell go against any guidance?
No, I'm not aware. We implemented the PHE guidance or UCSA guidance as it became.
Thank you. Inquiries heard on a number of occasions about the fact that the healthcare system in Northern Ireland is different to the others in terms of its level of integration. Integration means that the health and social care trusts are responsible both for social care and also provision of healthcare. That's right?
Yes, that's correct.
Did that structure help or hurt the provision of healthcare in Northern Ireland during the pandemic?
In my opinion, it definitely helped. From my own perspective, my thought processes were always about health and social care, and how a patient or service user or client manages their way through that pathway in an integrated and joined-up way. At the time, we supported the independent healthcare sector to deliver care, more acute care, out of hospital care. And we were able to do that by the provision of more IPC trained nurses from the trusts into the independent sector. We were able to open up training and provide extra training through our clinical education centre free of charge for primary care in the independent sector. And we shared PPE and provided PPE for the independent sector. It moved. I mean, obviously there were concerns about the availability of PPE, but we were able to share the supplies and make sure that everybody in a catchment area under the responsibility of the trust because they are the commissioners of the care of patients in the independent sector. So it worked very effectively as a system approach. And it also meant that, I worked very closely with my chief professional colleagues, chief medical officer, chief social worker, in the policy guidance and directions that were given to the whole community.
It sounded to me like all of your examples there were about moving from the healthcare sector into the independent of the care sector. Did that cause a difficulty in accessing resources in the healthcare sector during the pandemic?
Well, it certainly meant that from the acute trust provision, they had to provide more staffing out into independent sector to support care homes, their local care homes. But there was recognition that A, it was the right thing to do, and B, it smoothed the pathway for patients, and C, it meant that we could free up and keep the flow going through hospital. So for a very sick patient coming into hospital, the beds need to continuously move and circulate in order to be able to admit people, to admit them to ICU, to come out of ICU, to recover back out into the community. So to make that process work well, there was recognition that wider resources needed to be provided. So it was difficult. There's no getting away from the fact that there was limited capacity and a limited amount of staff. But the system working together in that way had a greater benefit.
I think you say in your statement that in Northern Ireland there are about 27,000 nurses and about 1,200 midwives. Is that right?
That's correct.
And is that the system at its maximum capacity, or is that the actual number of staff members that there were?
That's the actual number of... So the Department of Health doesn't record the number of nurses working in the independent sector. We have very good data on nurses and other healthcare staff working in the HSE sector. But that number that you refer to, 27,000, is the number of registrants on the NMC list working in Northern Ireland, registered as working in Northern Ireland.
Okay. Well, let's just think about the staffing within the healthcare sector as opposed to the independent of the care sector at the moment. At the start of the pandemic, roughly how many vacancies were there? Ideally in terms of the percentage of roles as opposed to raw numbers.
So the workforce data in 2019, the vacancy rate for nursing, registered nursing and midwifery was at 11% in 2019. And that is, I recall, the highest vacancy rate during those pre-pandemic years. And it stemmed back to previous workforce planning in 2009 to 2012, where the commissions are set by the department for the undergraduate and paid for by the department for undergraduate nursing and midwifery places. And at that time, in 2009, the commissions were around 790, and over that period it was reduced.
I don't want to go too far down the road about that, but you're saying that stemmed, those high vacancy rates stemmed from decisions that were taken
much earlier.
Yes. What did that 11% vacancy rate mean in terms of the number of nurses that there were available to work in hospitals, in primary care and other healthcare settings?
Well, that would be a significant level of vacancy. It's probably, in ideal terms, you would like a vacancy rate, in my opinion, of around 4%, which allows for natural turnover, retirements, moving, etc. So it was significantly higher. That, coupled with the impact of sickness and self-isolation, really meant, in reality, the availability of the nursing workforce would have been closer to 20%, 25% non-availability of work. So that was very stretching.
And at what time, when you just to pick up that 20-25% non-availability, at what point?
Well, if the vacancy rate is 11 at March or at the end of December, and we know that the sickness absence, I think, in the first wave was around 8%, and then if you add on a bit more for self-isolation, so in that early first wave, March, April time of 2020.
And that 11% figure, that's smoothed out over all roles, all areas. That's
yes.
right. So there will be areas where there are peaks, so there are higher vacancy rates. Is that
well? That's true, and there are traditionally areas in the health service that when vacancy rates become an issue, it's more prevalent in certain areas, and they would be medical unscheduled care, the pathway through the emergency department, for example. Theatres would also be a high turnover rate, and they're the areas that would emerge first. And I think it's also fair to say that the profile of the nursing workforce in Northern Ireland, 50% of that workforce are on Band 5, which is the entry-level grade into nursing. So 50% of those would be frontline care delivery nurses that you would meet in any ward or department or outpatient area in the hospital.
I'm going to come back to some of those specifics later on. We'll talk about ratios.
Okay.
But is it an effective summary that Northern Irish healthcare system didn't really have any capacity that it could afford to lose during the pandemic?
It didn't have any spare capacity. It was very stretched at the time.
So while you say that the systemic benefits as a system operate between health and social care, is it not problematic to the provision of healthcare if you then have to lose nurses to the provision of the independent sector?
Well, it means you're diluting your workforce further. But it's a balance of risk, and it's about how we enable the system to work effectively. Because there would be no point in keeping the staff in healthcare if we're unable to discharge anybody out of the system.
And those were conscious choices, I presume, that were taken to provide nurses to the independent sector?
Absolutely, by each of the organisations.
And do you think that they were decisions that were taken with the intention of trying to provide the best level of care for people in all different sectors?
Absolutely, and in terms of providing support to smaller providers, to independent sector, and to environments where there were actually less nursing staff, qualified nursing staff, dealing with much more acute care in nursing homes primarily that they wouldn't normally provide. They needed a higher level of both nursing and a slightly different skill set in terms of their expertise.
And on reflection, do you think that those decisions were the right ones or should have been taken in a different way?
It's the way the system works, and I think it was the right thing to do, and I really don't know how we would have done it differently.
I want to move now to visiting restrictions. You say in your statement that Northern Ireland led the way in ensuring restrictions were applied in a person-centred way. What do you mean by that?
So at the start of the pandemic, obviously we made a decision to restrict visiting, which is a normal protocol in terms of infection prevention and control. So you would see that happening across hospital systems where there's an outbreak of an infection where visiting is limited and restricted. It would normally be for a number of days or a week. And at the start of the pandemic, we made that decision that we needed to restrict visiting to protect very vulnerable patients, to protect our healthcare staff, and to protect the public. And those guidance, we didn't at that time think the pandemic would be as long as it was. So as we became more familiar with the virus, its transmission, the impact that visiting was having on families, and we heard many, many stories about the impact of that. Indeed, there were lots of communications both to the Minister's office and my office. And my small team worked to try and provide a solution to many of the queries that had been raised with them. But that was all fed into our decision making around our flexibility with the guidance as we move forward, which is probably why we had so many iterations of the guidance, because at every point possible we tried to flex them and be flexible, taking into account the feedback that we were getting from families and service users.
I'm going to go through some of the iterations.
Okay.
But if you're saying that you didn't expect it to last as long, does that mean that the intention when the initial visiting restrictions were brought in the 26th of March, that they were effectively intended to be short-term and that the intention was to keep people out in order to protect them and healthcare workers?
That would have been the normal thing to do in an infection control emergency, that you restrict visiting. So we used what we knew to be the best evidence base and to work well. But as I say, we had no indication that we were going to have a pandemic for the length of time that we had.
Yes, but in terms of the original intention, was it that there was meant to be quite a firm separation in the sense that you were trying to keep visitors out because you didn't think the restrictions would be in place for that long?
Yes.
And is it right then that effectively the ground moved under your feet and so you had to change the approach to allow people in?
Well, we were learning about the virus. We had a number of different variants of the virus. We didn't have a vaccine until the end of 2020. Testing was being developed. So yes, the ground was shifting on a very frequent basis in terms of the virus, the evidence we had, what we were learning, and what strategies we could put in place to protect people.
Yes, but right back at the very beginning, there must have come a point in time when you thought, our initial approach has to change because we have to let people in. Was that something that you then realised changes had to be made?
We did that very early on. We tried to make exceptions for palliative patients, for women who are pregnant, for children, for people with additional needs very early on, as best we could in the environment that we had at the time, and also understanding that the non-pharmaceutical interventions, the distancing, the wearing of masks, the hands, were having an impact.
But there wasn't a pre-pandemic plan for how to manage visiting in the event of a pandemic, was there?
No, other than the IPC manual.
Well, the IPC manual didn't provide for how you might approach visiting in the context of a pandemic, did it?
No, as I say, only in a normal outbreak situation.
Yes. If we can just go, please, to INQ 000376875. This is a document dated the 21st of April 2020, and it's created by the Critical Care Network Northern Ireland. Can you just explain who they are, please?
The Critical Care Network is a network which connects all of the intensive care units across Northern Ireland. They're funded by the Health and Social Care Board, which is the commissioner, which was at that time the Commissioner for Health and Social Care in Northern Ireland. They're overseen by a clinical leadership team and a manager, and they coordinate and deliver best practice and really network all of the intensive care units in Northern Ireland.
7 intensive care units in Northern Ireland?
7.
Are there 7?
I'd have to
Okay,
count them.
we'll go over the page and please tell me if there's any that are missing here. And this is dated the 21st of April 2020. If we could just please go to page 2.
Yeah.
Thank you. So this provides, in terms of the background, a brief overview. So on the 26th of March, it was all general hospital visiting was stopped. Is that the initial decision that you were talking about, where you realised there needed to be a break on visiting applied?
Yes, all general visiting.
Yes.
But there were exceptions at that point.
Yes, and the
Yes.
exceptions were critical care areas where one visitor was permitted, and another exception was those in established labour. Is that right?
Yes.
To what extent was the department monitoring how those exceptions were being applied by the trusts?
Well, I met, as I say, regularly with we had our Director of Nursing huddle meeting in the early days of the pandemic. Sometimes it was 3 times a day, but in the main, we met regularly at midday, and all of those issues were discussed at how those restrictions were being implemented, any issues that were being identified with them, and any possible changes that we could implement, because each of the directors of nursing and indeed the nursing staff were very conscious of the impact that this was having on families.
You were being informed by the trust about how they were applying these?
Yes, and then as we moved through the process, and you maybe want to come to this later, when we changed the guidance to have local ability to deviate through risk assessment, but at that point that was reported on a weekly basis to the Minister.
Again, just in terms of the timeline, on the 9th of April, there was an update. With immediate effect, all intensive care and general hospital visiting across Northern Ireland has now stopped.
Yeah.
And then, although palliative care outside of intensive care was listed as an exception. There was no exception for those patients receiving end-of-life care within intensive care units.
Yeah.
Why was that decision taken on the 9th of April to stop all intensive care visiting?
I deeply regret that we had to make that decision, but we were in the peak of the first wave. We were expanding our capacity for ICU. We had additional ICU beds in most intensive care units, some of which had limited space. And you will appreciate that an intensive care bed comes with both a lot of kit and a lot of staffing requirements. And it wasn't possible in a high-risk area with aerosol generating procedures and the implications of donning and doffing to enable staff to allow visitors in through the donning and doffing process to be extra people in an already very confined space, and when our staff were extremely stretched at that point in order to provide direct care. So for that period of time during that first wave, we had to further restrict visiting, and we reverted to virtual visiting at that point.
How long did you expect those restrictions to have to be in place for?
Only during the peak of the wave, and they actually...
If I can push you a little harder, how long roughly was that?
A couple of
1 week?
weeks.
A couple of
Yeah.
weeks. And did that view influence your decision about needing to go so far to prevent any intensive care visiting?
My view that it would be relaxed within a couple of weeks.
Yes.
I felt at the time we were between a rock and a hard place. There was nowhere else to go with this. It wasn't a decision that I either wanted to make or would want anybody's family to have experienced. But it was a balance of risk between protecting patients, staff and the public. And I really do understand the implications of making that decision. I've had very personal experience not being able to visit my own mother when she died in hospital. So I do understand.
In the middle of April, there was a review conducted. Was that because you realised the toll that it was taking on people?
Say that again, sorry?
In the middle of April, there was a review conducted about visiting at the end of life in intensive care.
Yes.
Was that because you realised the toll that it was taking?
Absolutely, yes.
If we can please just go over to page 3, because I want to see how that end of life in intensive care was being applied. So we have there at the top, there's a list of, this is where the number 7
Yes.
came from, intensive care units. There's no one missing there, is there?
I don't think so.
Okay. And then if we can just go down to question 1. It says, does your unit recognise end of life as a special circumstances and allowed loved ones to visit where possible? So this is 21st of April, this document.
Mm-hmm.
End of life visiting was permitted at that time. Is that right?
The 21st of April.
Well, it wasn't expressly forbidden, that's right, isn't it?
Yes, it wasn't. So even in this extremist part of the wave, if staff could have facilitated a visit in any way, they would have done so. And of that, I'm pretty certain.
Because the reports you were receiving back was that only 2 units out of the 7 facilitated end-of-life visits. And one of those was non-COVID, and the other did have COVID-19. What was your view about the difference that was being applied by the different trusts?
I think there are a number of different circumstances to be considered here, and I am absolutely certain that where possible, staff, nurse in charge and nursing staff try to accommodate even a short visit where they knew a patient was at the end of life. It depended a lot on the environment and the estate, I suppose, of the intensive care units. And they had expanded out into outside intensive care units, so they would have had patients potentially in theatre recovery and other areas. And so depending on that environment, the availability of space, the availability of staff, the sickness of the patients, all of that needed to be in context of supporting people to come in at end of life. And so I do understand that some areas were better able to facilitate that than others.
Did you think at this point, well, ask a slightly different question. I'll come back to that one. If we can have up, please, INQ 000 475219.
While the document's coming up, Professor McCardle, can I just check? At this stage, the document to which Mr. Scott has just taken you was dealing with intensive care units. And so all general hospital visits had been stopped.
Yes.
And so the only hospital visits that were taking place were some hospitals were letting families go in for end-of-life
Yes.
visits, and 2 units were letting people in for end-of-life visits to intensive care. So things like maternity wards, there were no visits at all there. Is that right?
So for maternity, at all points, a pregnant lady was allowed to have a birthing partner in active labour.
And that's throughout?
Yes.
But not around.
Sorry?
Not around active labour, simply in active labour at that point.
Yes.
So birthing partner during active
Yes.
labour. And is that the only other category of visit that was permitted?
Yes, we did also make exception for children to have one parent with them very soon after that period.
And what about people who had particular needs, like somebody who was used to a carer or somebody with dementia?
Yes, and again, that was down to discretion of the nurse in charge. And for people, it was in the guidance, people with additional needs should be discussed with the nurse in charge to accommodate that arrangement.
Sorry to interrupt. You will be coming to it, Mr. Scott. I just
What guidance did you give nurses in charge about how they should apply their judgment at that time?
Well, their guidance was set out in the region guidance, which then would have been supplemented by trust guidance and support for them through their senior line manager. So again, this is down to circumstances on the day, when we encourage people to use a risk-based approach to accommodate people where possible. And at all times in the guidance, we iterated the need for people to have their family as part of their wellness pathway or an end of life. And we recognise the importance of that, being person-centred and thinking about individuals rather than a bland approach.
Is that right on the 26th of March, or did that come later on?
That came slightly later on, as I said, as we became more familiar with at that point in March, it was really a decision based on safety.
But you, and when I say you, those within the Department of Health had taken the decision from the Department of Health to prevent visiting. What guidance was the Department of Health giving trusts about how they should apply those exceptions?
So they should apply the guidance in its totality.
This document that we have up on screen, it's the PHA and CNO COVID-19 regional huddle, and it's held on the 17th of April 2020. So it's a couple of days before that CCANI document that we were just looking at. And this is a section of visiting policies in that meeting. And those top 3 paragraphs, I presume you've had a chance to have a look over this document. It doesn't appear from those paragraphs that the decision to allow visiting was being driven from within Northern Ireland. It looks like Northern Ireland was responding to views that were arising from in England and in Scotland. Is that right?
Well, as stated there, the Secretary of State at the time had said that no one should die alone. We were very aware of that, and we were coming down from the peak of wave 1 at that time anyway. And as I said, the measures that were put in place were done so purely during the peak of wave 1, where we were seeing maximum numbers of intensive care patients for wave 1, I think was at 57, increased medical admissions, etc. So, and the peak was the middle 2 weeks of April. So we would have been considering how we could flex and reduce the very tight restrictions that we had anyway, and we were very conscious of the need to have people, particularly for end of life, for maternity and for children.
Hesitant to apply too literal a reading to a note of a meeting, but again, it doesn't seem like there's a real driver from those present at that meeting that visiting is something that absolutely had to happen at that point in time. Is that fair or not?
I can assure the inquiry that visiting was, if you look at the minutes of the huddle meetings and other nursing meetings, it was a regular feature. It was forefront of everybody's mind. It was an issue that we spent considerable time on.
It may have been something you spent time on, but there's a difference between spending time on discussing the topic and people saying in a meeting, this is absolutely something that has to happen now. Was anybody making that point in the middle of April 2020?
Yes, I think all of the directors of nursing, myself, were working to expand and reduce the rigidness of the guidance. And we were reviewing that on a daily basis. That was my point about the meeting, is while it may not be documented in your minute here, the purpose of us having that discussion was to be as flexible as we could and extend the opportunities for people to visit.
If that can come down now, please, if we can go to the arrangements of visiting patients who are approaching their end of life. That was published on the 11th of May 2020, and that's at INQ 000120721.
While that document's coming up, and I apologise for keep interrupting, you said at the beginning when Mr Scott started asking you questions about visiting restrictions that Northern Ireland led the way to ensure that the restrictions were applied in a person-centred way. What did you mean by you led the way?
So, a lady further on in the pandemic, we developed two specific pathways, one for hospital and hospice care and one for care homes. And while this module is not looking at care homes, obviously, in an integrated system, we devised policy guidance for both. And we developed a care partner scheme, which we implemented from effectively the guidance went out in September 2020, which recognised the need for families to be with people in long-term care, for families to be present with people who had additional needs in hospitals. And that care partner policy was the first of its kind. It was evidenced from Canada, and in terms of the 4 countries, we were the only country at that point to have such policy. And indeed, in my current role, I've been working in NHS England to develop a care partner policy for NHS England with patients, families and advocates like John's campaign and the Patients Association.
Those features that you're relying on came in later on in the pandemic. Would you say that you led the way at the start of the pandemic in terms of visiting?
No, I think we were doing what other countries were having to do and make very difficult decisions.
So the document we have up on screen is the 11th of May. This is what followed on from a review. At this point in time, you're well past the initial period of time you thought the visiting restrictions would be in for. Is that right?
Sorry, which?
So let's go to page 1 of this document, just so you can see it. It's the 11th of May.
Okay, the 11th of May. Right. Okay. Yeah.
Yes, there you go. Thank you. And if we can just go back to page 7, please. In this document, this is where you set out fairly strident principles in terms of what's expected. Mm-hmm. So we see at paragraph 3.31, people have the right to be with a loved one at time of death, and this should be respected and accommodated where possible. I mean, that's the starting point, was it? That people should be applying when they're considering visiting restrictions?
Sorry, I'm having trouble hearing you.
That was the starting point that
Yes.
should be applied when people were considering applying visiting restrictions. Is that right?
That people should have a right to visit.
People
Yes.
have the right, yes.
Yes.
And then if we can just look at paragraph 3.3.5, that only in extreme cases should family members or loved ones next of kin be denied the possibility to be with a patient at the time leading to or of death. Reasons should be clearly outlined to the patient and family members and or loved ones. And then if we can also look at 3.3.8, please, that infection prevention and control requirements should not be so rigid as to prevent family members / loved ones from saying goodbye in as humanely a way as possible that includes the ability for them to hold hands and touch the dying person. Do you think those fundamental principles were being followed by trusts in Northern Ireland in the summer of 2020?
Yes.
Were you receiving any complaints, comments, suggestions, thoughts by family members that those weren't being followed?
I had several complaints from families about restrictions on visiting and access to services. I'm not aware of any particular case that was in relation to a person dying. I am aware of a number of cases where people had travelled from other countries to come to visit, and when they arrived to see a dying relative, usually a parent, they were unable to visit, and in those circumstances where that was known, a solution was found to accommodate them.
How did you ensure that these principles were being complied with by trusts?
Because I was in daily contact with directors of nursing who have responsibility for the provision of patient experience and services in those trusts, and I was assured by them. I was also in contact with staff, and I wasn't hearing that they were unable to accommodate visiting. I was hearing their concern, absolutely, about having to find ways around issues to support people to visit.
Are you satisfied then that in every reasonable instance, let's not say every instance, but in every reasonable instance that people were able to be with their loved one at the point of their death?
Yes.
Is there anything more that you think you could have done or should have done to make sure that any of these principles were being complied with?
I think that we did our best in the circumstances. We tried to be flexible with the iterations of the guidance as new evidence became available, as we became aware of particular difficulties. And I'm not sure that I could have personally done any more, or my team. It was a very difficult time, and decisions were the least worst option.
Okay. Just in terms of the timing of the dissemination of this guidance on the 11th of May, isn't it right that you'd actually provided a briefing paper on the 6th of May that enclosed this guidance?
To the Minister?
Yes.
Yes.
Why did it take 5 days to come in?
The Minister, obviously I produced the paper to the Minister. The Minister was receiving a lot of papers from different policy areas. There was a lot going on in the department. And him and I potentially, although I don't remember for certain on this occasion, would have discussed the issues before he signed off the paper. And it may have come back with queries from the Minister before the final paper was agreed.
Well, if I can just take you then to 103665. Just on that point of queries. So that you have that's gone to the Permanent Secretary and the Minister, dated the 6th of May.
Yeah.
If we just go, please, to page 3. Those are responses from the Minister on the 4th of May. Are you aware of the reason why it took 5 days for that guidance to come in? Or is this a question better put to the Minister?
Or is this a question about?
Better put to the Minister.
I think that's a reasonable time frame given the work that was going on in the department, the fact that we were in a pandemic response, the fact that the Minister and his team had questions that required answers before he signed it off. I think that's appropriate challenge on the Minister's behalf.
There was then the next iteration of guidance was on the 30th of June 2020, which was the regional principles for visiting. And if I can please take us to INQ 000 103667, at page 11. So this was the advice that had been given at the end of June. So it's another step beyond the end of life guidance that had been on the 11th of May, that's right.
Yes. So
It appears from this grid that depending on the surge level, that actually there were times when the end of life guidance was being watered down. Is that fair or not?
depending on the level of, as set by the UK CMOs. So it was clear from March to June that there were a number of instances where people were confused by the number of iterations of the guidance, and we set it out in this format so that the public would be clear, based on the alert level, what they could expect in times of visiting. So in high surge, and I think the only other period that we had alert level 5 during the pandemic was the third wave in January 2021, where again, if you look at the guidance, there were restrictions on ICU visiting for a limited period of time during the alert level 5. But it was an effort to try and make clear to people so they could go to the website and link our visiting guidance to the alert level, and also to provide clearer guidance for staff so that they could plan more effectively on the alert level.
But why did the principles that we've been looking at the 11th of May, why would they not have been able to apply during the higher extreme surge period?
Because we said in extreme circumstances, it may be that visitors could not be accommodated, and that was an extreme circumstance in UK level 5
But
with a new variant in January 2021.
But then again, wouldn't that only have applied to COVID settings rather than non-COVID settings? Because at that point in time, you had different pathways.
We did have different pathways, but the nature of the virus, it was very hard to maintain pathways. And we do, as part of the visiting guidance, we did a review of the evidence around the impact of visiting on nosocomial transmission in particular. And the studies that we looked at, the COVID study, which you'll appreciate at that time was early, evidence suggested that patients had a role in, or visitors definitely had a role in the spread of infection. We looked at a SARS paper and we looked at a MERS paper, and both of those indicated, the MERS paper indicated that 12% of infection spread in hospital was due to visiting, and the SARS paper had no nosocomial spread, but they had really restricted no visiting at all, even in a paediatric unit. So I think we were aware of the evidence, and we knew that in high surge, where the virus was in a lot of circulation in communities, and the transmission routes coming from communities into hospital, that it was too big of a risk to take in the peak of the surge. And they were the only two times during the whole pandemic that ICU restrictions on visiting to that extent.
Okay. But this applies to non-COVID general wards as well. Surely you haven't got the same considerations in a non-COVID general ward in 2021 or 2022 that you would have in ICU.
But given the spread of the virus from community transmission, the risk is bringing that virus into the hospital and then spreading it among vulnerable, susceptible patients who are acutely ill with medical conditions, many of which are respiratory anyway.
So what use did you make of testing to make sure that you knew that they were negative at that point?
For patients, for relatives?
Patients or for visitors?
At which point?
2021 or 2022?
In 2021, our testing capacity was being developed. We had lateral flow testings. They were, as you may know, a high false positive or false negative rate. We had other measures, IPC measures in place to non-pharmaceutical interventions to support the reduction of nosocomial spread. But even at all of that, the risk to vulnerable populations and people in hospital is significant, and also to the healthcare workforce. The vaccine only began to be rolled out at the start of 2021. So at that point in January, we didn't really have widespread vaccine. We only were starting to protect the most vulnerable in our society.
I'll move on. Were you aware of concerns being raised about the inappropriate use of DNA CPRs in Northern Ireland?
No, I wasn't. And I think if you're referring to inappropriate decisions being made, in my professional opinion, that would be totally unacceptable and out with any code of conduct of any healthcare professional.
I'm more interested about whether you were actually informed that there were concerns.
I wasn't. And the department developed an ethical framework to support clinicians to make those decisions in very difficult times, recognising that they are decisions that unfortunately are made on a day and daily basis by our clinicians in hospitals. So the guidance was to support them in this extra challenging time to do that, and that then followed with a subsequent bereavement support guidance for staff and for people who had been affected by the pandemic.
Staffing numbers and particularly nursing ratios in the surge times. So it's right, isn't it, on the 1st of March 2020 there were 88 critical care beds in Northern Ireland.
That's correct.
And I think the first wave surge plan, the final version was dated the 17th of April. Does that sound about right to you?
Yes.
And that indicated a need for 140 COVID and 35 non-COVID critical care beds. So effectively doubling the number of critical care beds. Is that right?
Yes, but we did also develop a surge plan that took us past that to...
Yes.
Yeah, okay.
But that
At
was
that
what was
time,
intended,
Yes.
that you were looking at effectively doubling the number of critical care beds. Was there ever the nursing capacity that would have been able to deal with the number of critical care beds that were anticipated?
It would have been extremely challenging. It would have meant reducing the ratios significantly. It would have meant taking further action to reduce other services and to bring additional staff into work in ICU, as most countries did have to do anyway, to support the critical care nursing team to deliver that care. So in normal times, a 1-to-1 ratio for a ventilated patient was not going to be possible.
Can we please have up INQ 000377063? And this is feedback from nursing staff about the workforce, and it's noting a conversation on the 23rd of April 2020. That conversation didn't involve you.
No, but it involved one of my senior nurse advisors, which I brought in to support me in the pandemic.
So you would have been aware of the discussions that were going
Yes.
on. And if we can please go down to paragraph 3.4. And it's talking there about the modelling, and it's talking about effectively going up through the ratios. This is the 23rd of April. Can I please take you to INQ 000438043? This is a letter that you sent to the executive directors of nursing across the 5 trusts in Northern Ireland. It's dated the 22nd of April, so the day before that conversation. And then effectively this letter says, delivering care staffing should be adhered to as far as possible. At this point, suspension of delivering care, nursing and midwifery staff should exercise professional judgment in determining safe staffing requirements that maximises, and then over the page, please, the knowledge and skills within their teams, and if necessary, adopting a more task-based approach to the delivery of care. There seems a disconnect between that letter on the 22nd of April, where you're effectively saying to the trusts, you need to look after the staffing numbers based on the information capacity you have available, and then the discussion the next day that's talking about nursing ratios.
So we had a safe staffing policy in Northern Ireland from 2014, which covers broadly medical, surgical and other specialties. The ICU module of that safe staffing policy hadn't yet been signed off prior to the pandemic. So we're talking about slightly different things here. The ICU guidance was from the Critical Care Society, and they're very well known and standard nurse staff ratios for critical care for levels 1, 2 and 3. The letter was a broader letter, recognising that in order to accommodate ICU expansion, we would have to move staff from other places and other wards. And in order to do that, we could no longer meet the safe staffing requirements of the policy in 2014. And indeed, it was on the back of a conversation with the directors of nursing who were looking for my support to share the workload and move people around, and they needed me to stand down that policy in order to do that safely.
Was that effectively what happened, that it was just moving people to wherever they were required across Northern Ireland?
It was moving people, yes.
were you actually capable of setting staffing ratios, or was it simply going to be, we have capacity issues here, we're just going to have to put people in those places?
We tried to maintain staffing ratios as best that we could in order to maintain safety. I think there were limits on what we were prepared to do and not do. We all recognised that it was extremely challenging and we would have to dilute the staff, but we could not have a situation where there would be no nurse in charge and no nurses with skills to care for patients in any unit. And certainly in intensive care, it was agreed with the network, and you see in that evidence paper the proposal to stay at 1-to-1 for as long as possible and then move to 1-to-2 and 1-to-4. And I don't believe that during the pandemic we ever moved past 1-to-4 in any ICU situation.
Was the fundamental problem a lack of nurses?
Yes, we didn't have capacity to do what we needed to do.
Okay. Because in October 2020, isn't it right that you asked chief nursing officers in England, Wales, Scotland and the Republic of Ireland if they'd provide you with extra staff?
Yes, that's correct.
And no one was able to help you?
Correct.
How bad was the situation in October 2020 that you needed to ask the other nations of the UK to provide staff?
At that time, we had particular challenges, particularly in relation to intensive care and our ability to flex up. So we were monitoring the ICU bed usage through the critical care network on I would say a twice daily benefit basis, and I was in regular contact with the ICU hub on a regular contact, and I knew that we had a small number of beds that we could still staff at the required level in October. But if we had a sudden surge or an event where a number of ICU beds would be required, for example, in a non-COVID situation, that would be very challenging for us. So this was an attempt to plan for the worst case scenario. And in fact, the agreement with the Republic of Ireland was that while they couldn't transfer staff, they would be able to take a number of patients for us if we needed to.
Did the numbers available impact upon patient care in either the first wave, second wave or third wave?
I think that it certainly impacted on our staff's ability to deliver the care, and I am quite sure that that impact on staff had an impact on patient experience, at least. I don't think we have the evidence to say that it impacted on someone's outcome, but it certainly impacted on experience of both staff and patients.
You had the workforce appeal. I
Yeah.
think it's right that actually there weren't a huge number of people who returned in terms of nursing
Correct.
staff through the workforce appeal. Why were the numbers so low about who was able to actually then rejoin? Or have you set that out in your statement? Because I'm just conscious of the time.
Yeah, so we ended up with 447 nurses from the workforce appeal. The numbers did drop significantly from those who had applied to those who ended up. That's correct, and there were a number of reasons for that. Many, I think, felt an emotive response to the call for action, and I certainly was very vocal and visible in that call to action. But they didn't necessarily, why they want to work in frontline services, didn't necessarily have the skills, the particular skills that we needed, or they had very rigid rotas that we couldn't facilitate. Others wanted permanent jobs that weren't going to be provided through this workforce appeal. So there were a number of different reasons, and in some ways I think we had better success with the vaccination programme.
But in terms of the workforce appeal for numbers, particularly when you're going through that second wave, was there anyone who had expressed an interest or made an application through the workforce appeal who you think may have been able to provide the skills, but actually the way that the workforce appeal was structured meant that they weren't then able to be deployed? I'm not asking for individuals, I'm just in terms of, did you make available use of everybody who expressed an interest?
I can't answer that question because I wasn't directly involved in the workforce appeal, and the trusts would be better placed to answer that.
Again, this is one thing that we hear frequently, is the trust's a better place to answer that in terms of the management of the Nightingale, the workforce appeal. Is there not a lack of control from the Department of Health when these issues are then passed on to the trusts?
I don't believe so. I think that the Department of Health have a very specific role in overseeing the health and social care system. During the pandemic, we became closer to that system in a number. I was very involved operationally, but in terms of the response to the workforce appeal, it was managed through HR and the Workforce Policy Director at the department. And what I'm saying to you is I'm not close enough to know the detail of that.
Just a few very minor questions left. Sorry, not minor questions, just a small number. That's what I meant to say. The RQIA suspension, we can ask the CMO about the reasons for that. Were you asked what view you had about the impact of suspending the inspection of the hospitals by the RQIA would have upon the protection of healthcare workers?
I don't recall being directly asked, but I would have been aware of the conversations between the Chief Executive and the CMO at the time. And I understood that the direction that was issued from the department was on the back of a conversation with the Chief Executive of the RQIA at the time, who had a professional background. She was a nurse and saw the opportunity for RQIA staff to be more helpful.
Yes, sorry, I'm sorry to cut across you, but in terms of, is there a benefit of a regulator such as the RQIA maintaining inspections of IPC provision in hospitals? Is that beneficial during the pandemic?
I think that the flexibility allowed them to inspect if they needed to inspect. I think that during the pandemic, their staff provided a more beneficial role in the work that they undertook in terms of supporting particularly independent sector and working with the Public Health Agency in particular around communication and management of outbreaks and supporting healthcare staff. I think the trusts have an IPC team, a very skilled and expert IPC team. There are processes in place in organisations to oversee IPC, and I would also note, I think, the RQIA report, when they did visit hospitals, suggested that in the main, with a couple of recommendations, there was a high standard of adherence to the IPC guidance.
Yes. And finally, the impact upon nurses. Did you come to learn about any concerns or issues that are being faced by ethnic minority nursing staff?
I was aware of the information from the other countries in terms of the mix of healthcare staff. I think it's fair to say in Northern Ireland we have a different population mix probably than the other 3 countries. And because we have a smaller ethnic minority mix, I think, and again we would have discussed this through both IPC Cell and the nursing huddles, the nurse directors and the senior nursing teams were very aware of where those staff were located. And I understood that all of the same level of support and was provided to them as to all other members of staff.
And then finally, in terms of, was there sufficient provision being made for nurses who were suffering from long COVID?
Again, that's something that I wasn't directly involved in from a policy perspective, but I do know that there was a group at the Minister's request set up to examine the impact of long COVID and the provision of services which were set up in Northern Ireland through a clinic. I myself became aware of the work of Dr. Elaine Maxwell and the work that she'd done reviewing the international evidence around sequelae.
And I think you've set that out in your statement.
Yes, okay, thank you.
Thank you. My lady, I have no further questions.
Thank you. Some more questions, Professor McArdle, on visiting restrictions. First of all, one of the core participants has asked, when you mentioned additional needs for the purposes of making individualised exceptions to visiting suspensions, what was the guidance on in additional needs?
It was simply additional needs, so it's broad enough to cover anyone who has a specific set of circumstances, should that be a learning disability, a mental health issue, a dementia, a child with additional needs, any patient or service user who has a requirement to have another person with them, either act as an advocate or to communicate on their behalf.
The other question they've asked is, you said that you felt the principles about family visits at the time of death or about the time of death were applied in Northern Ireland. The suggestion is that there is evidence that exceptions to the visiting restrictions were not always subject to an individual risk assessment, and that patients with additional needs or at the end of life were not permitted to have visitors or family carers with them. Now, you've said you relied on your directors of nurses and contact you had with frontline staff. Were there any other steps you had to take to monitor whether what you were being told was actually happening?
Well, my lady, as I said, whenever we move the guidance on to provide more flexibility and to take account of local transmission, so in one area of Northern Ireland you might have had a population with a high transmission rate presence, and in another lower transmission. So the flexibilities for organisations would depend on that as well. But in the case where organisations moved away from any of the regional guidance, they reported that on a weekly basis through me to the Minister. So that was the assurance that organisations were adhering to the guidance.
So if they didn't allow or didn't conduct risk assessments because they had a high number of cases, that would be reported to you. And are you saying you didn't get any such reports?
I'm saying that where they deviated from the guidance, so say, for example, they didn't allow an end-of-life visit, they had to document why that was so.
And did you get such reports?
We did. Well, we got a very small number, but there were exceptional circumstances, and whenever we went back to the individual organisations, they were able to explain why, specifically on that occasion, the guidance wasn't adhered to.
Thank you. Right, I think you've got a question or two. Oh, you're over there. Well done. Can you see?
Yes, thank you.
Are you on?
Can you hear me?
Yep.
Yes. Good morning, Professor. I ask questions on behalf of 13 pregnancy, baby and parent organisations. And we'd like to focus on restrictions on parents and families being with their babies in neonatal units. Would you agree, Professor, that parents, and in particular both parents, being with their babies on the neonatal unit is a positive thing not just for parents but also for babies, for the health and development of those babies?
Yes, I would agree.
Could you perhaps explain some of the ways in which that's important?
Well, it's important for bonding, it's important for family interventions, it's important to ensure the growth and development of the baby and to have that support network around them from parents. It's also an important opportunity for staff to talk to both parents in a neonatal unit where obviously there is a very sick child, and to prepare them for whatever the outcome is going to be, hopefully positive, and to educate and support them at the time.
Thank you, that's helpful. Is it right that it wasn't until the 7th of May 21 iteration of the visiting guidance, the pathway to enhanced visiting guidance that you were speaking about, that as a general rule, both parents were permitted to be with their babies on the neonatal unit at all times?
Yes, that would be correct. There was provision for one parent.
Prior to that guidance?
Yes.
And so it wasn't until May 2021 that, as a general rule, both parents could be there at all times?
As a general rule, but as I say, at that point, local risk assessment was in place. So where that could have been facilitated, it would have been facilitated.
And so, given what you said about the importance of family care to these, by definition, very vulnerable babies, and given what we also know about the very severe and distressing impacts of restrictions in this distinct context, do you agree, as your Welsh counterpart said she did yesterday, that parents should always have been considered as one unit for the purposes of so-called visitor guidance in this context, i.e. that both should have been allowed to visit?
I think that that will be down to individual circumstance. I think it will depend on the mix of the babies in the neonatal unit, as you said, are very vulnerable. They're immunosuppressed, immunocompromised, and a risk assessment should be made based on the environment, the babies, the staff and the parents. And where possible, I think, of course, yes, both should be accommodated. At the start of the pandemic, when we did not understand a lot about the virus, we were learning as we went along, that would not have been possible. And I think on reflection, it would be which is why we amended the guidance so many times to support people to be more flexible. But as I've said previously, these were very difficult decisions that nobody wanted to make, and they were made in the best interest of protecting young babies, families and the public.
Thank you. And finally you've spoken about the guidance being kept under continuous review, about Northern Ireland leading the way in this respect. The charity Bliss, which advocates for sick and premature babies, received reports, including from neonatal staff at one trust in Northern Ireland, of restrictions on wider family access, so by siblings, grandparents, continuing all the way into May 2023, with COVID-19 being given as the justification. Are you aware of that happening?
I'm not aware. I'm aware of it happening in line with the guidance during the pandemic of 2020 and up until, as you say, 2021 when we made that change. I left my post in October 21, so I can't really comment on what happened after that period.
So you're not able to assist us if that was happening, in fact, all the way into 2023, why that might have been happening?
I can only, I would understand from my experience that would be down to local circumstances in the neonatal unit at the time, potentially the number of cots, the number of staff and the physical environment of the unit.
Thank you, that's helpful.
Thank you.
Thank you, Melanie.
Mr Wilcock?
Professor, I represent Northern Ireland COVID Bereaved Families for Justice, and Mr Scott has helpfully already asked you most of the questions we wished to ask you, but Her Ladyship has given us permission to ask you two relatively short questions in relation to visiting restrictions. Before I do that, can I just confirm, you told us, haven't you, that you've had lots of communications about the impact these restrictions were having on people in hospitals and care homes during the course of the pandemic?
Yes, that's correct.
And just for the record, can I say that I'm not asking you about care homes for the very simple reason that, as you pointed out earlier, the inquiry has made clear to us that would not be within the scope of this module. And it may be that Her Ladyship will consider recalling you to give evidence on this topic in a later module on care homes. So I'm really only asking about hospitals at this minute. And many of the families I represent have reported what they see as inconsistent implementation of the visiting restrictions that were in place in different hospitals at any given time. And in that context, can I ask you these questions? First of all, do you agree that any impression that visiting restrictions were being inconsistently implemented was inevitably confusing and distressing?
I agree, it was confusing and distressing, but I think it's a complex area, and I think it's subject to the virus, the local arrangements as I've described, local transmission, hospital estate, availability of staff, risk assessment of the patients. There are a number of complex factors to be considered, and I appreciate that that is not easily understood for people from a non-healthcare background. And in that context, yes, it was somewhat confusing and indeed frustrating for the public.
So given the balance between we accept the complexity of the situation you were dealing with and the distress that would be caused to individual affected, apart from your decision whether or not to answer the complaints you directly received, what was the formal review or complaint mechanism in place for someone directly affected by what they saw as an inconsistent application of the visiting guidance, so that they could register their view and receive from the healthcare system the explanation for what was happening? What was the formal system in place?
Well, there were two systems in place. Firstly, through the trust caring for the patient in the normal complaints procedure, contact through the nurse in charge and on up through their organisation, and a formal complaint if necessary, and also the patient and client council as a route to advocate on their behalf. And indeed, patient and client council did work very closely with us and I accept your point about care homes, but they were engaged in that process through with other patient association groups, patients who'd come to them, and they were a very good source, and indeed they carried out a survey for us, which was very helpful in feeding back people's experience of visiting policy.
My lady, two questions occur to me. They're very short and they probably already occurred to you. May I ask them?
You may, Mr Wilcox.
Thank you. So there was no individual system, there was no system specific to the pandemic, it's just what existed before?
It would have been normal governance processes in the health system.
Was that sufficient given the distress of the inconsistent application would cause?
I would be of the opinion that if anybody raised a concern with the nurse in charge or with the trust and the organisation, they would have made best efforts to rectify that situation, as did happen in the number of cases that I was aware of.
Well, comment may be made on the phrasing of that answer, but I have no further questions. Thank you.
Thank you, Mr Wilcox. Thank you very much, Professor McArdle. Those are the questions we have for you. As Mr Wilcox has presaged, there is a possibility we'll have to ask you to come back, and I'm sorry about the impositions we make, but thank you for your help so far.
Thank you.
I shall return at 25:02.
All right.
Ms Carey.
Thank you. May I call, please, Professor Susan Hopkins, and may she be sworn.
Please repeat after me. I do solemnly,
I do solemnly,
sincerely and truly
sincerely and truly
declare and affirm
declare and affirm
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Lovely. Do sit down.
Professor, your full name, please.
My name is Susan Hopkins.
Thank you. You've made a statement to Module 3 dated the 31st of January with the INQ ending 410867, and I think you have a copy in front of you.
I do.
Right. Professor, I've got a number of topics to deal with you over the course of today. Can I just start, please, with your personal background? Is this right? You are a Professor of Infectious Diseases and Health Security at University College London.
Correct.
And you maintain what is described as an active research portfolio, and you continue to work clinically as a consultant at the Royal Free Hospital.
I do.
You, in 2021 in October, became the interim chief medical advisor to UXA,
I did.
UK Health and Safety Agency, but we're calling it UXA for short, and then was formally appointed to the post in June 2022. Prior to joining UXA, is this right, you were the Deputy Director of the National Infection Service at Public Health England from
Correct.
2018 to 2020. I know there's various other responsibilities you have, but that will probably do for our purposes. Can I ask you, please, we have heard a little about the WHO, World Health Organization guidelines, and I just want to establish at the start, is it the position that the UK is bound to follow WHO guidance and or advice?
Absolutely not. I think, first of all, the consensus that WHO will come to will actually be a consensus bringing in lots of different countries, and UK will usually be a member of those advisory groups that help inform WHO advice. It is really important to recognise that each country develops advice for their own situation, but that the evidence base that we are using tends to be very, very similar, and the knowledge that we are sharing both nationally and internationally tends to be from the same evidence base.
Right, but the WHO doesn't mandate action in any given country, is that right?
Correct.
And if the WHO advice is not followed, presumably there's no sanction or anything like that?
Similarly to guidance in this country,
Right.
likewise.
Well, we're going to come on to the UK guidance. All right. Can I deal with, firstly, Public Health England and a little bit about their roles and structures, and then deal with the same with UXA, just so that we're clear about the two different bodies. I think, is this right? Public Health England, or PHE, was set up in 2013.
Correct.
with the aim of protecting and improving the nation's health and well-being and reduce health inequalities. And they are to carry out the Secretary of State's statutory duties and functions to promote the health and well-being of the nation.
Correct.
Right. And during COVID, did Public Health England have the following two roles? They were to provide scientific advice and guidance to the Chief Medical Officer,
Correct.
translate SAGE's advice into guidance for clinical settings and audiences,
To all settings and audiences,
Thank you.
not just clinical settings.
and they were to undertake specific scientific tasks, for example, testing and contact tracing.
Those were some of the tasks, yes.
Quite, yeah, there's a lot more. Right. Is this the position that Public Health England acted as advisors to the UK IPC cell?
So UK PHE and subsequently UK HSA were one of the teams of advisors to the IPC cell. It was all of the public health agencies and the NHS coming together, and therefore had a role in advice, but as did the advice coming from SAGE or the expert groups from SAGE as well, or other advisory groups from government. All of that came together within the IPC cell.
Yes, it wasn't to the exclusion of the other public health
Absolutely
agencies,
not.
but we'll look at the IPC cell a little later. And if anyone wishes to know more about PHE's engagement with other bodies, it is set out in full in the statement, and I'm not going to go through it with you now. UXA came on the 18th of August 2020. The Secretary of State announced the new body. It went through various names, which I won't trouble you with, but is it right that it name changed to UXA on the 24th of March 2021, and UXA formally launched on the 1st of April of that year?
So it formally launched with the chief exec and the chair on the 1st of April, but actually it came into formal action on the 1st of October of 2021.
And their responsibilities and roles included preventing and anticipating threats to health and help building the nation's readiness, defences and health security. They had detection functions, an analysis function, responsive function, and to what's called lead strong and sustainable global, national, regional and local partnerships designed to save lives and protect the nation from public health threats and reduce inequalities.
Correct.
So what was the real difference between that and Public Health England?
So Public Health England included infectious diseases, external health threats, health improvement or non-communicable diseases, so things like obesity, smoking. Public Health England also held the public health grant that was given to local authorities on behalf of the department. UK HSA does not do non-communicable diseases, health improvement such as obesity, smoking, alcohol, and the lead role for health disparities or health inequalities sits with the department as part of the Office for Health Improvement and Disparities, the other half of what PHE was.
So in an event of a future pandemic, the burden is going to fall on UXA.
So I think the operational burden will fall on UK HSA. It will require the whole of government, and it will also require the department in its role with health improvement and disparities to work with us very closely on those elements.
Can I ask you about one other group that we've heard of? Is the Senior Clinicians Group. Is that the same thing as the Senior Clinical Leads, do you know?
Well, I presume it is. I've seen both used. I think we called it Senior Clinicians Group because it wasn't necessarily just leads from organisations, and individuals were invited to that to provide views or opinions so that a range of people from a range of organisations across the four nations could come together.
Right. And I think in your statement you say that the Senior Clinicians Group, it was convened by the Chief Medical Officer's office. It included the Chief Medical Officer, deputies, the NHSE Medical Director. Was that Sir Stephen Powis predominantly for the time
It was,
we're dealing
yes.
with? The NHSE Director of Emergency Planning. Who was that, please?
That was Professor Keith Willett.
Thank you. The PHE Medical Director.
That was Yvonne Doyle.
Thank you. And then there was a PHE Incident Director.
That was me and Professor Nick Finn, who we shared that role for the first 9 months of the pandemic.
And the Senior Clinicians Group first met on the 16th of March 2020, and the membership gradually widened to include the four nations' chief nursing officers, the CMOs and relevant DCMOs, and with various experts invited to attend individual meetings. Is that
And that was very rapid. I think within a week it was a Four Nations group.
Professor, can I ask some overview questions at the beginning, predominantly about transmission? Do you agree that determining the mode or modes of transmission has consequences for the IPC measures that are recommended?
I do agree, but I would also highlight that when we determine the mode of transmission and the measures that are going to be done, we use a lot of information that has developed over many years and evidence that's developed over many years in the literature for both the mode of transmission, but also the evidence for what we will do.
All right. I think you're aware that we are familiar with three main routes relevant to respiratory viruses: the droplet route, the aerosol route. Do you agree that airborne and aerosol are used synonymously?
So I think, can I just, I'll put this in a really simple way. I think that in traditional terms, there's been dichotomies, simple binary dichotomies, that I think the pandemic has shown are not helpful.
Pause there, please, because we're going to come on to that.
Yeah.
But I just want you to understand that we're aware of the three main routes. We'll look at whether they are good ones, bad ones, or perhaps ought to change in a moment. But to go back to my question, do you agree that generally airborne and aerosol are used synonymously?
Airborne and aerosol are, I don't know if it's used synonymously. I think aerosol is meant to be a component. Airborne, I think, more aligns with respiratory route of transmission.
All right. Well, for these purposes and the COVID-19, yeah. And obviously we're familiar with contact, both direct and indirect, or fomite, however you want. So they're the three routes we are going to be concentrating on. In your statement, when you refer to droplets, what particle size are you referring to?
So I think if we look at traditional measures of droplets that were used throughout the early days of the pandemic, droplets were regarded to be larger particle sizes that would fall close to where the patient's attached, where the patient is or where individuals are in the public. I think that there were dichotomies and measures that are taken, and we can discuss those. But I think that, again, this was about simplifying complex matters into terms that people could understand.
And so in the vein of simplicity, in your statement, what droplet size are you referring to when you say droplets?
So I think in the statement, I think what it's referring to is that the traditional infection prevention and control measures that were used for droplets were large particle sizes, usually in the order of multiple microns to hundreds of microns wide.
All right, can you give us a figure? We're going to come on and look at the 100 dividing line, but I just want to understand what your position is so that people know at the outset when they see in the statement of Professor Hopkins referring to a droplet, she is talking about a particle size of what?
So I'm afraid I think that I would say that the traditional particle size of droplets and aerosols that have been used throughout the pandemic have been based on evidence that was built on for many years. The aerosol droplet size has traditionally been measured as a sort of 5 micron, things that get into the narrow parts of the lung. But I would also highlight that what we have done and the evidence that has emerged during the pandemic means that that dichotomy is no longer useful or helpful.
I follow that, and we will look at it, but I just want to understand some basic parameters at the outset. So when you are talking about aerosols, you are referring to particle sizes of 5 microns or smaller, is that correct?
That's the traditional
All right,
mechanism.
and can we take it then that if it's above 5 microns, that is potentially you referring to it as a droplet?
Correct.
Right, thank you. Are you aware that Professor Beggs's evidence was that particles of 100 microns or larger behave ballistically?
I am aware from...
You've read his
yes,
statement.
I have.
Right. And he says that particles of under 100 microns or under behave like aerosols, i.e. they float and travel larger distances.
So I recognise that that is the particle physics that he describes.
Now, do you agree with that dividing line?
So I agree that the dichotomy of 5 microns versus 100 microns is not helpful, and that we should recognise a range of particle sizes that come through. I think that what we've seen emerge throughout the pandemic is that these simple dichotomies are not helpful in understanding how transmission occurs and the interventions that can control transmission.
do you think that the 100 micron dividing line is about right?
I again think we should be thinking about respiratory transmission in general and about the range of particles that people emit through a range of procedures, and that actually what we are seeing from all of the evidence accumulation in the pandemic and a review of a lot of the evidence before, that we should be talking more in general of respiratory transmission and what we can do to reduce it rather than talking about particle size per se.
I follow that, but it would be helpful to have on the record whether you agree the 100 micron dividing line is a sensible one. You may say 110, you may say 90.
I mean,
give us
give
us a ballpark figure.
Well, I think that the problem is that if we develop into a new number as a dividing line, then we don't actually overarchingly think about what are the measures that we can do to reduce respiratory transmission and what are the interventions that are helpful in doing that. And so in my way of thinking, what we have is a continuum of particle sizes that go from very small to much larger, some that are visible by the eye and the majority that are not visible by the eye, and things that we can't measure routinely in practice. And therefore, what I think is really important in thinking about that is what are the interventions that will help us reduce the risk of respiratory transmission in a wide variety of settings to prevent people getting infected.
All right. Do you think in future there needs to be a more multidisciplinary approach to the formulation of IPC guidance? It's not just clinicians, but with physicists, engineers and the like.
I agree that the multidisciplinarity is important. Multidisciplinarity occurs in hospitals with the hospital engineers contributing to IPC teams. I think, again, the feeds into the IPC cell who are writing the ultimate guidance for operationalisation in the NHS were multidisciplinary through the advisory groups, which are multidisciplinary to government, and specifically the SAGE environmental modelling group, which had multidisciplinarity. So I think the feeds in need to be multidiscipline because they will bring in all of those aspects. And then I think that in developing the guidance, it needs to be thought about the range of individuals who will be using that guidance and whether it's understood by them and can be practiced by them.
So just going back to your answer, Professor, how can we reduce the risk of respiratory infection in a wide range of settings? That sounds as if you don't think there's any purpose whatsoever in deciding whether it's aerosol or droplet transmission, because circumstances can vary and you ought to be catering for every possibility.
So I think what we've learned...
reasonable possibility.
Yeah, I agree. So I think what we've learned through the pandemic is that respiratory transmission occurs in a wide variety of different ways. And that when we're looking at the ways of controlling it, we need to look at a wide variety of ways of controlling it. Knowing who's infected, knowing the risks of the person who may be about to see somebody who is infected, knowing how we can improve the ventilation that in the environments, whether that be through temporary measures or more permanent measures, thinking about how we isolate individuals and quarantine them, having widespread testing available. And I'm happy to go into this in more detail, but I think it's really important to recognise that a golden bullet or a silver bullet won't work if we just think about it in binary terms. And I'm really keen that coming out of the pandemic, that we understand the multidisciplinarity that's important, but also the multiple different interventions that we need to use at once as complex interventions to reduce infection transmission.
All understood, Professor. But the bottom line is that early on in the pandemic, droplet transmission was deemed to be the main route of transmission.
Agreed.
So it may well be now in 2024, our understanding has evolved, if not changed. But I do need to deal with what was known back in 2020 and onwards. So in that vein, as at January 2020, I think it was Public Health England that published the first COVID-19 IPC guidance on the 10th of January, and that's paragraph 290C if you want to look. As at the 10th of January, what was Public Health England's understanding about the mode or modes of transmission?
Well, the emerging information that was essentially shared with us from WHO was that the main mode of transmission was close contact transmission and likely, therefore, to be related to droplet transmission, as that close contact was the predominant route.
Right. And so that accorded with Public Health England's understanding?
So that was the best information. We had no information in country at the time.
And then at that time in January, we know that shortly after that guidance, COVID became an HSID, a high consequence infectious disease, and that accordingly, therefore, various precautions were needed, including the use of FFP3 respirators when dealing with an HSID. Is that correct?
Correct.
It was declassified in due course on the 19th of March. All right. I'm not going to ask you about the classification and declassification decisions, but is this the position that the January 2020 guidance was based on MERS guidance?
So we had established guidance for MERS and for SARS and for diseases that were neither endemic, epidemic or pandemic. So these were all very rare infections that were not circulating in the community. And so the only exposures that we would see in the UK were imported cases that were then being managed in healthcare settings. And therefore, it was very clear about that what we wanted to do was reduce the risk of any transmission when we are trying to find out more information.
Now, putting aside the fact that MERS was designated as a high consequence infectious disease, the MERS guidance said that MERS was transmitted by large respiratory droplets, direct or indirect contact. It may also have been detected in blood, feces and other bodily fluids, and under certain circumstances, airborne transmission was thought to have occurred, particularly from aerolized respiratory secretions. So a number of routes of transmission for MERS there. And MERS guidance recommended FFP3, is that right?
Correct.
Now, of course, it was an HSID as well, so that may add a complication into it. You mentioned, I think, SARS. Do you agree that SARS was transmitted by the airborne and droplet route as well?
So again, the majority of evidence from the SARS epidemic from 2003 was that the majority transmission was through droplet. And actually, it was from the SARS epidemic that occurred that the idea of aerosolized generation procedures actually came to the fore, predominantly because the people who had just worn no face masks or only fluid-resistant surgical masks were transmitted in healthcare, having performed a procedure, an aerosol generating procedure. If those people were in doing other forms of healthcare, so normal healthcare routine delivery, without FFP3s, we didn't see transmissions. Transmissions occurred at those AGP moments. So a lot of the evidence that we use for MERS subsequently is based on what we learnt from those hundreds of cases that were then transmitted in other countries during SARS.
Right.
Could you're like me, you speak very quickly. Could you
Sorry.
slow down, don't worry. It's just that
I'm
some of
trying
the
to
words
keep
you're
up.
using, I'm watching the transcription. And, it's not
Right.
easy.
So you've got MERS transmitted via a number of routes. You've got SARS transmitted via airborne and droplet, but the majority is considered to be droplet transmission.
Correct.
You have the WHO considering that COVID was droplet and or contact transmission. But obviously there is some reference to airborne in, and I'm trying to understand why at the outset airborne seemed to have dropped off the radar, if I can put it like that.
Yeah, I think that when we look and when we consider airborne, and we've got a number of diseases that we consider airborne, we often think about transmission at long distance rather than short distance. And what we saw during the early cases that were identified for SARS-CoV-2, as it's now known, or COVID-19, that the cases that were being identified were very close contact, and that those were predominantly within a metre, but definitely within 2 metres. When we have looked at airborne transmission for other infections, and I think the two classic examples that are often used are TB and measles, where actually transmission often occurs in the next door room or in another environment where you can see that it's has to transmit through the air because it's not been in the same room. And we see that in healthcare as well, particularly for things like TB and measles, where we know that these can jump from room to room. And that's where the traditional component of transmitting through the air for these infections has occurred. Whereas for infections that are transmitting to people within the same close confined space has been traditionally used as droplet.
Right. So in relation to COVID, it was considered to be droplet, and therefore the risk was greater the nearer you were to the infectious person.
Correct.
Can I ask you this? When did Public Health England first consider there was evidence to suggest that COVID-19 was transmitted via the airborne route?
So I think that was an accumulation of evidence over time. I don't think I could put at a single moment. This was not just Public Health England's evidence, but other evidence from other teams globally where we regularly reviewed the evidence. A lot of that evidence came together at advisory groups where Public Health England was one of many providing evidence, either through SAGE subgroups or to NerveTag. And I would say that by the 2021, we were pretty clear in 2021 that there was some element that was happening through the air, but that even then, there was thought to be lots of other circumstances around why this might happen. For example, PHE was doing studies all the way along on in hospital rooms and in collecting air samples and collecting it from the environment, so the touch surfaces that people touched. And in doing those studies, we were reviewing the analysis at each point. And in those, we only found 2 samples where it was through the air, one in a room that an AGP had been performed, and another in a room where lots of people had merged into that room to provide healthcare, and there was thought to be disturbance in the air. And those things were all sort of saying, it is definitely possible, but it's not dominating because these are rare events rather than finding it in the air at all times.
Can you help us with when the UK IPC guidance first mentioned that COVID could be transmitted via the airborne route?
Well, I think it mentioned it for aerosol generating procedures from the start.
Put those to one side because
Okay.
that's a specific, but just generally.
So I cannot recollect when it particularly mentioned it. I do recall that in UK PHE, as it was then, brought together independent experts to do a respiratory evidence panel in spring of 2021. Yeah. In that spring of 2021, along with experts from SAGE Environmental Modelling Group, there was a consensus that there was at least some airborne component, and that should be started to be reflected in the guidelines. It was probably later than that where it was full on that there is clearly airborne. I think that was probably 2022.
Yeah, we think it's either the end of 2021 or certainly by January 2022 when there's reference to either wholly or it became predominantly airborne transmission, and we'll look at the terminology later. All right. So spring 2021, I think you said among with other groups, there was a consensus by that stage that it was capable of being transmitted via the airborne route.
There was definitely a consensus that there was some components of transmission were covering through the airborne route, but that the dominant mode was still close contact through droplet.
Right. Do you agree that where there is an accepted risk of aerosol transmission, FFP3 masks should be recommended?
So I think this is, again, quite a complex area. And I think that, if I may, I would say that when we look at the components of fluid-resistant surgical masks versus FFP3 masks, we look at the evidence that we have available and their effectiveness of use, both the laboratory evidence, which is one element, but then the evidence in clinical practice. And where we looked at it and repeatedly looked at it and are still looking at it, the evidence is weak that they actually, FFP3s, protected more than fluid-resistant surgical masks. And the judgments from many of the consensus groups that were being discussed is that there was a whole host of interventions that we needed to do, that FFP3, and I'm sure you've heard mentioned before of the hierarchy of controls, is at the very bottom of the hierarchy rather than at the top, and that the other elements were more important to be introduced rather than a binary fluid-resistant surgical mask.
Follow that. Pause there, please, because you're right. FFP3 is part of the PPE, which is at the bottom of the hierarchy of controls. But I just want to come back to what you said. I had understood the position that respirators offer a higher degree of protection to those wearing them than those wearing an FRSM mask. Do you agree or disagree with that?
So they offer a higher degree of protection that's been studied in laboratory procedures. When we look at it in clinical trials of various different types, it is very mixed actually, and in some studies there's no difference between them.
If that were the case, why bother pushing them on then for AGPs at all?
So again, AGPs are pushing out what was thought and what is considered to be thinking is that AGPs are pushing out a large volume of aerosols, and you're in very close proximity to the individual, and that higher level of protection therefore may help. When we're looking at wider airborne, what we're trying to do is a variety of different components of control, and we are looking at all of the different elements of practice to try and reduce any elements of respiratory transmission. I would say that if we were to look at the evidence and use and require FFP3s, then given people are coming to hospital with respiratory viral infections all the time, then we would be asking people to wear them all the time, but we don't. We ask people to wear them at very specific moments, using all of the other elements as a priority.
Professor, can I just ask you this? I understand that you're drawing a distinction between the level of protection that is deemed as a result of a lab-based experiment, and you said it was different in a clinical context, but if in reality in a clinical context it makes no difference, why on earth is there all this controversy about whether you should wear an FRSM and an FFP3 if in reality it makes no difference?
So, I think that we can ask lots of people that question. I think that there's benefits that are seen where you can eliminate the risk of an infection. However, when you're in the middle of a pandemic, you can't eliminate the risk of infection. What we know is that healthcare workers and the community were suffering infection rates at the same, roughly the same rate in the population, because the infection was transmitting and around us in all places. Therefore, what you're trying to do in healthcare is to really, where the risk is considered greatest, provide the greatest level of protection to bring that risk down to where the level of protection is for everyone else that is circulating.
Quite. There's a load of infected people in a COVID ward and nurses having to deal with them day in, day out. There's going to be a higher viral load, and therefore you want to protect the healthcare workers from contracting COVID. And the way to do that is FFP3. So
that would suggest that all of the transmissions in healthcare occurred from a patient to a nurse. We know that's not the case. The transmissions were occurring from healthcare worker to healthcare worker, from healthcare worker in the community. And I think that it's really important to be able to reduce the infection transmission risk to the level that is circulating at all levels in the community at the time.
Forget who brings in the infection, whether it's the healthcare worker, a visitor when they were allowed, or the patient. If there's lots of people in a ward with COVID, there's going to be a higher viral load in the room, is there not?
If they are in the early course of disease,
yes.
Yeah,
quite. And in those circumstances, I just want to understand why, if there's no real difference between the protective measures provided by FFP3 and FRSM, there has been such widespread controversy, why it dominates the IPC guidance, if you, as you say, there isn't any real difference in a clinical setting.
Well, I think that's one of the challenges that we have, and one of the things that we need to learn from post-pandemic and understand better, because actually there were harms from wearing FFP3s as well. There was blistering on faces, and they were significant harms. I think that from my point of view, that having these discussions in the middle of the pandemic is very challenging, that we need to have an ongoing discussion and ongoing evidence about whether these masks actually do protect people better in real life settings and wards.
So if there were a pandemic in a year's time and we're back in the position we were at the beginning of 2020, what would your recommendation be for healthcare workers on a general ward? What level of mask should they wear?
So again, I think it would take the level of risk that's on the ward that's there I think it would take the level of ventilation that's on the wards that's there. And I think that it would also take the views of the healthcare workers and the views of the evidence. I think that it's really important that if the evidence was strong, that FFP3s really protected people from it, and we saw definitive reductions in it, it would have been recommended. Even at the end of the pandemic, this was low quality evidence and it may have reduced infection. And those words are really important, I think, when we're thinking about future evidence. I think that we need to bring this actually as a learning point for the future about how do we develop pandemic guidance before the pandemic occurs, so that people are actually able to input into it and be able to provide that rationale and discussion at that point.
Well, whether it's right scientifically in a lab or in the clinical context, clearly we need to look at the fact that there were distinctions drawn between FRSM and FFP3. Can I ask you this? What was the evidence base for deeming COVID to be transmitted via the droplet contact route at the start of the pandemic?
So that was based on the studies that were performed in China and then in other countries about how many people were infected and what the proximity to individuals were that were being infected. It was based in this country when we started to see cases on looking at where the infections occurred and how the infections occurred in the community and in other settings. It included collecting specimens from the environment where the individuals were with infection, both in the home environment, but in the healthcare environment and in other workplaces as well, from samples taken from surfaces, samples taken from air, and samples taken from contacts.
Right. And do I take it, therefore, that PHE considered the evidence base sufficiently strong for that to be then the cornerstone of the IPC guidance? It's droplet and contact mainly.
So I think that the evidence was sufficient for us to have that knowledge, both from our organisation, but from all other public health organisations and health organisations and evidence organisations globally.
Does it follow that PHE did not consider there was sufficient evidence of aerosol transmission at the start of the pandemic?
Correct.
If there was no evidence to include it, was there evidence to exclude aerosol transmission at the start of the pandemic?
It's very difficult to exclude elements.
If it couldn't be excluded, why wasn't the guidance based around the fact that, well, we don't know, so we're going to take a precautionary approach and recommend IPC guidance that covers droplet, aerosol and contact transmission?
So I think it's important that IPC guidance is built on the years of evidence that have gone before and the evidence that we've had from other respiratory viruses, influenza, MERS, SARS, and the evidence that we've used in previous pandemics and in other studies as well. So the evidence is not just based on the precise information we have, but multiple documents that people are constantly reviewing, new evidence that's emerging. And that when we think about the approach to IPC, the aim for infection prevention and control that is taken nationally and internationally is very much about reducing the risk. It was not possible in a pandemic to eliminate the risk because we were all having events happening to us in the community, on travel to work, in our households, that were causing transmission. So this was not an event where you can eliminate risk in healthcare, because risk will be there outside healthcare as well.
Of course, there's nothing to stop the healthcare worker getting on the bus and catching it on the way to work and then going into the hospital and infecting other people. I follow that. But why doesn't the guidance say at the start, we think it's droplet and contact, we can't exclude aerosol, and therefore, at the moment, we are recommending the highest level of protection until we know more about the route of transmission?
So my understanding is that the pandemic COVID-19 guidance was based on the pandemic flu guidance, which again is a respiratory virus. And while there are differences, I think that in Professor Begg's report, he highlights the similarities as well. I think that the important point here is that IPC guidance is there to facilitate the use of a wide range of interventions to reduce transmission in healthcare. And that is based on the evidence that is available to us at the time, or that is evolving. We would rarely say, oh, all of these other things need to be done as a precaution, because that has risks and benefits. And in medicine, we use risks and benefits and looking at the various different elements at all times. At the very outset, so in March 2020, the risks were that we had never asked people to wear FFP3 masks for prolonged periods. Actually, when we saw that, we saw them get ulcers on their faces and have challenges in breathing and in challenges in being dehydrated. That was clearly important. The second point is that FFP3s were not routinely used in healthcare, apart from specialist teams, such as teams I've worked on, because we manage infectious diseases regularly, and therefore that healthcare workers weren't fit tested, and therefore could not have been rolled out at speed or at scale. It would have taken many, many, many months to do that everywhere. And actually what that may have done is taken the use of FFP3 to places which was considered at lower risk at the time, rather than places that were considered at highest risk.
I follow that, but that comes down to whether we've got enough FFP3, which...
Not just enough FFP3, enough people to train people, enough people to test people, enough different types of masks, and also whether that risk was proportionate to the benefit of doing it. And it was considered, as it is for much IPC, that was the risk balance here was in favour of fluid-resistant surgical masks for the majority, and FFP3s for those with the highest risk procedures, based on what was known already.
All right. So does it come to this, at the start of the pandemic, let's call it March 2020, although there was no evidence to exclude aerosol transmission, one of the reasons, or the reasons why it wasn't recommended, is because there's a comfort issue, the fit testing issue, it's not routinely used, and there was a need to prioritise it for those areas deemed to be at highest risk.
And the evidence wasn't there for their use.
Yeah. All right. Can I ask you this? There are many who think that rather than being led by the science, it was the lack of FFP3 that drove that early IPC guidance and caused it to not recommend FFP3. What did you say to that, Professor?
I don't recall that was the decision-making process.
Now in 2024, what is UXA's position about the routes of transmission for COVID-19?
So I think COVID-19 is a respiratory virus, and as with many other respiratory viruses, that there is a route of transmission that is through the air, and that is not just big droplets that are close, but smaller droplets that may be within 1 to 2 meters, and that there's some components of those droplets that can stay in the air, of which some of those may be infectious and infect other people. So a range of droplets, a range of sizes of respiratory particles that comes out of the mouth, and a range of those respiratory particles that may be infectious.
Yeah, and presumably contact.
And I think that contact is still potentially a role, as for many other viruses. I think that the idea that we are going to throw hand washing out in managing infection would be a wrong thing to do. Not only does it manage this, but it manages many others.
So although the language would be different now in 2024, in reality, you're saying all three routes of transmission are considered to be the routes for COVID-19?
I think all 3 routes, but I think it's important to recognise that the closer you are to somebody and the longer you spend with somebody, especially in a confined space, is most likely to result in transmission.
Okay, now you've alluded a number of times to the fact that you don't consider the dichotomy between droplet and airborne to be useful any longer, and indeed you've written as such in letters, I think indeed one to Mr. Jones from Qatar. If that distinction is no longer useful, what does that actually mean now for IPC guidance? What is it going to say, Professor?
Well, I mean, again, I can give you my view. I can give you some of the view from my organisation, but I think this needs to be a consensus exercise across multiple scientific disciplines to bring this together. I think that we need to separate out what we think is the route of transmission and how we think that route of transmission goes to the strength of evidence for the interventions that we need to do to reduce that mode of transmission. If I may, I would say that in healthcare, one of the biggest things that we can do to reduce respiratory infections that happen every single day and transmissions of respiratory infections is to improve the ventilation in healthcare and also consider where patients are placed in delivery of healthcare, whether we have enough single rooms, how we can use those rooms effectively. I then think that we need to think about ensuring that we can test people regularly so we know what they have. And that we think about the individual level risk mitigations that people have, including vaccination. So vaccination very much changes people's level of risk and their perception of their own level of risk. But of course, many healthcare workers vote with their feet and decide that they don't no longer need vaccination for COVID or flu or many other things. I then think that there's the final element then, and there's many other elements that I could go into, but the final element is in relation to masks. Personally, I think that we should have an enabling situation with FFP3s, and I call it enabling rather than mandating. And that means that people are able to judge their own personal level of risk better, that they are able to get fit tested regularly, that there's a range of masks available to fit them. For example, I know that I only fit 1 or 2 masks and lots of other masks don't work for me. So that means that organizations need to be able to have all of those skills in place in order for people to be able to take their view on the risk and the risk on the procedure that they may be doing. I then think that in terms of evidence, I think what we've seen in terms of the evidence that has developed throughout is that FFP3 masks may, and I think all of it says may, provide a higher level of protection than fluid-resistant surgical masks. I think we need to look at that better. I think we need to provide and perform studies better in the NHS to allow us to understand this better in between pandemics so that we are ready for pandemics. And that I think that when we are considering how we work with healthcare workers to inform their level of risk, that is very much informed about the environment they're working in, the organisation they're working in, and how that we need all of those things to come together to improve our IPC guidance from where it is now, which is still in the dichotomy mode, into much more a patient level and a healthcare worker level of risk.
Do you think, therefore, that the terminology, the dichotomy, to use your words, needs to be clarified and or changed?
Yes.
Do you know if there's any work ongoing, put the WHO to one side, in the UK to try and reach agreement about the terminology that should be used for a respiratory virus?
So we are working within our organisation to develop the better evidence base. I think one of the things that we need to do, and which we are doing, is working with a wide variety of different scientists and looking at...
Slow down.
Sorry.
Sorry, it's an awful lot of substance. And,
Sorry.
Right.
We're working with a wide variety of scientists of multiple different disciplines to try and come up with consensus statements, which is one of the things that we try to do during the pandemic in difficult scenarios, because I think each organisation may have different views on the practicability of it, the operationalisation of it, the feasibility of delivery. But I believe that we need to have that sort of consensus statement in the UK ready for the next pandemic, but also ready for the day-to-day management of respiratory infections in the NHS.
Is that, do I understand it, that's work being done within UXA?
Within UXA, but also with our advisory committees, the NERVTAG, Advisory Committee for Dangerous Pathogens, etc.
And what about across the UK with the public health agencies in the devolved nations?
Yeah, well,
is that work started?
So I think, again, within the public health agencies, we have forums within the 4 public health agencies to come together. We have a health protection committee and a health protection oversight group. We share regularly our views within the public health agencies. I think it's important that there's a public health agency evidence, but then I also think it's important that the operationalisation of this evidence is considered by the NHS.
Her Ladyship heard, I think, in earlier evidence in another module, the suggestion that UXA appeared reluctant to admit airborne transmission outside of AGPs. Do you agree or disagree with that statement?
I think that as it changed over time and as the evidence evolved, I think that we did acknowledge this, and actually it's acknowledged on our website. But I think that we were cautious in the early days because of the lack of evidence. And as an organisation, we needed to ensure that we were taking views from many different parts of our organisation with many different views in it, but also the evidence that was collected not just by our scientists, but by scientists from other organisations in delivering statements on government websites.
Can I just ask, I don't know if you read Module 1 report in which I spoke about groupthink. A lot of the evidence base you're talking about seems to have come from a group of scientists who say around the world, and the WHO then uses that expertise. How do you ensure that there isn't just an element of, well, we all think this is droplet, so the WHO says it's droplet, so we're all going to go along that path, and you just end up confirming each other's, is it called confirmatory bias? I can't remember what it's called in scientific terms. But how do you stop that kind of groupthink developing? Whether it's right or wrong, how do you stop a bunch of scientists all saying basically the same thing? Nobody's saying, but wait a minute, the emperor's got no clothes.
So first of all, I think systematic reviews are one of the big things that we do in medicine and in health delivery in general. And so that's about independent individuals who have got expertise and gathering together from a wide variety of different sources, weighing up the strength of evidence in that in it, and summarising what it says into whether things are low quality or high quality evidence and the range of outcomes that it's looking at. Those evidence reviews were often done rapidly in the pandemic because they needed to be done in days or weeks rather than a prolonged period of time. In normal time, we would normally take 1 year to do an evidence review. It would have lots of different meetings, bringing people together to hear a wide range of opinions. And I think it's really important that a wide range of opinions are viewed, and in many cases in internal conversations or in conversations across organisations, those are. But then at the end of the day, we have to reach scientific or health consensus. And that is where everyone's views are heard, that people are able to provide the evidence for their view. And then where that evidence is not robust, that we are thinking about what science do we need to do next to improve the evidence there in order to base the consensus on the decision of most. It's really important, though, that consensus decisions in health are not one and done. They're decisions that are change over time, which is, I think, what we saw during COVID-19. Lots of things changed over time. So new information, new evidence was constantly being reviewed, and that allowed people to change opinions. But it doesn't change fast, because if it would change fast, then we wouldn't have an evidence to do that. But if something big came about, then that's what would happen. I mean, I can give you the example, for example, Mpox that we dealt with recently in 2022 started out as a high consequence infectious disease. We learned quite rapidly it wasn't airborne, it was mainly close contact. And therefore, we de-escalated the high consequence infectious disease. And that's the way that we do it. And so it's not about rigidity of thinking, it's about having an open mind, learning from everything that we see, bringing that together from a wide variety of different angles to then share that in summary. And I think in the environmental modelling group did that really well for the environmental stuff, because they brought together such a wide range of opinions to then summarise where the evidence was and where things were weak or low and where further work needed to be done.
Can I just, and I'm sorry to interrupt, Ms. Carey, can I just challenge, you say that the evidence base in the early days of the pandemic was such that the consensus became that it was droplet and close contact. But did you really have that much evidence in the early days? I mean, so you're relying on some research carried out in China, and no doubt because you couldn't really examine that in maybe the ways you'd like to. There may have been problems with that. Other than that, you knew about cases which had been exported. But how did you then know that it was close contact? I mean, what was the evidence base at that stage to come to the consensus that it was close contact and droplets?
So, I mean, it can give you lots of different examples on that. So each country, as individuals were identified in country, we're doing very detailed investigations around cases. So if I can give you the examples here, for the first 2 cases we identified in late January 2020, we tested lots of people around them to try and understand. We looked at all of the different elements that they had done in their infectious period, and we called the infectious period 2 days before they developed symptoms until they were isolated. And we could only find transmission in those very close contact individuals. We didn't find transmission in taxis. We didn't find transmission in a dorm room. We didn't find transmission in restaurants. Equally, what became known as the cluster related to skiing in Brighton, which again had quite a number of cases involved. We did a detailed investigation internally, but then also with all of the other countries where cases were, to look at what their contact was, what the route of transmission was. And there was no infections identified in people who had transient contact. We tested and looked at and followed up for symptoms, a variety of different households, a variety of different workplace settings. And that's where all of that slowly emerging evidence, that's just 2 examples, but I could, every single case in those first hundreds had a detailed investigation around it, where we were following people on a daily basis to see if they developed any symptoms and testing them very regularly if they did. And so it was all of that that brought us to the understanding of how it was transmitted in the best way that we could over time. And we continue to do that.
I'm no scientist, as you obviously will know, but there were limitations on the work you carried out. I mean, for example, you said 2 days, you were tracking them for 2 days before their symptoms showed. You didn't know how long people were infectious at that stage, did you?
No, we didn't. And again, that's an approach that we take for many respiratory viruses, where we recognise that people often have very mild symptoms they wouldn't recognise in the day or 2 before. And so we always went back 2 days prior to where those symptoms. What I'm saying is that even in those 2 days prior, we would not find people who they had transmitted to outside people who had been in very close contact with them.
Ms. Carey.
One final question, because I'd like to move on, Professor. You said a moment ago that you think that PHE were cautious in the early days. There are many in the room who think PHE were not just cautious, but slow to accept airborne transmission, and in particular, the possibility of far-field transmission. Now, some years on, do you agree or disagree that PHE was slow?
I think developing evidence is slow. Making statements as national organisation requires evidence. It's therefore our job to ensure that the statements that we make are fully evidenced. And I think that we tried to do that and showed a variation in approach in doing that over time as the evidence consensus built.
Is that a no?
So I think it's no.
All right. Can I turn, please, to the UK IPC cell? I think you are aware we've heard quite a lot of evidence in the last few days about the cell and indeed about how the guidelines were drafted, what level of sign-off, my words, not anyone else's, before ultimate publication. And I just want to be clear what PHE and in due course UXA's stance on it. Do you agree that it was the IPC cell that drafted the guidance?
Correct.
That it then went to the senior clinicians group?
No.
Right. Help us then, what happens after it's drafted by the UK IPC cell?
So I think, first of all, it varied at different times during the pandemic. And so that's really important because it was not one size fits all. The first IPC guidance that PHE released was emergency guidance. That was done by PHE. The second IPC guidance was guidance that the Deputy Chief Medical Officer, Professor Jonathan Van Tam, commissioned from NERVTAG members as the pandemic COVID-19 guidance. That was cleared.
Is that the March?
That was the March guidance.
Thank you.
That was cleared by NERVTAG and advisory committees, was reviewed by public health agencies and the NHS, but was essentially signed off by NERVTAG.
And the UK IPC guidance?
The UK IPC guidance, so the UK IPC guidance really became as a routine from thereafter.
So From the April guidance onwards.
April guidance
All right,
onwards.
fine, okay. Put the pre-UK IPC cell guidance to one side.
Yeah.
It is drafted, I think you agreed, by the UK IPC cell. And then once we're in April 2020, was it then that it went to the senior clinicians group?
No, it was. It would. So this IPC cell was the operational cell led by the NHS, and this guidance was for the NHS and had 4 public health agencies inputting into it, as well as the IPC nurses and leaders, doctors from NHS England. The IPC cell guidance was then ratified by the IPC and by their senior responsible officer.
It's my fault. You're right, I missed out that stage. You're right, we heard that it had to be ratified by each of the public health agencies and whatnot, and then went to the senior clinicians group.
The senior clinicians group was not a sign-off group on this. The senior clinicians group had moments where there was sufficient differences of opinion that the chief nursing officers could not come to an agreement on. And then it was escalated to the senior clinicians group. I can only recall a few occasions that happened. One was the guidance that we released in early April, wearing face masks for all, because that was out with traditional IPC guidance. One was the shortages guidance, which went to the senior clinicians group for discussion. And then at various points, the senior clinicians group discussed components of it, but never ratified it, and it was not ratified by the senior clinicians group.
So to use your words, who had sign-off?
So the sign-off was the IPC cell.
And if we've heard evidence that said that PHE signed off, I assume from that answer you would disagree with that.
The IPC cell was there to create the 4 Nations IPC guidance for operationalisation into the NHS. UKHSA published it on behalf of the 4 Nations, and that was really important. And one of our roles was to ensure that it was consistent with other guidance that was on gov.uk and other guidance that was being published, and that it had the same principles in it that were sitting across government as a cross-government document. From our point of view, that was not us saying, you are wrong, IPC cell. If we thought there was some consideration where we thought we needed to be reconsidered, that was asked for the IPC cell to reconsider it and gain consensus.
I see the distinction that is drawn, but we heard yesterday from the chief nursing officer that PHE could effectively say no. I think indeed Dr. Ritchie said, I'm paraphrasing, effectively the same thing. Can I ask you this? Because there may be some confusion, and it may not help now to go through the rights and wrongs of it. Was it set out anywhere? You draft it, we approve it, you publish it?
You shared an email that earlier on that you might want to bring up, which I think was highlighted the sort of sign-off for publishing. But I think it also highlights in that email that you shared, that was from early February 2020,
right,
that it went back to the IPC cell if there was disagreement. I think can I just come as a doctor and as a healthcare professional, and somebody who has worked in healthcare in this country in lots of different ways. Firstly, and in Public Health England in lots of different ways over time. There is no situation where Public Health England has had a veto about something that's happening in the NHS and for any guidance that's delivered into the NHS. That is not our role. We are advisors. We try and bring together scientific evidence. We try and support organisations in their delivery. But there is literally nothing that the NHS delivers is we would have a veto. Quite rightly, because we are one part of it. Equally, in something that was for a 4 Nations approach, Public Health England is one of 4 public health bodies, and health and public health is devolved. And there is no occasion that one organisation could therefore rule other organisations, and nor would it be expected. And equally in things like senior clinicians group or advisory groups, the idea is always to try and drive a scientific or health consensus rather than a single component driving out decisions, because that's not helpful in delivering a system level approach to anything in healthcare.
So no one has the right of veto. Public Health England want to ensure there is consistency before it's published with other agencies, departments who've put out things on the website and the like, but that's not the same thing as you saying, no, that's the wrong guidance. Am I understanding that correctly?
Correct.
All right. And does it come to this then, that once the IPC cell reach a consensus, effectively, no one's going to overrule it unless it diverges from something that you see another government agency or department has put out?
Another government agency, another government, another organisation, if it disagreed with SAGE recommendations, for example, it would be reconsidered. Really important that the IPC cell took advice from various subgroups of SAGE, various advisory bodies for SAGE, various government advisory bodies like NERVTAG, and that it was about taking all of that in and translating what was scientific advice to government into an operational guidance that could be delivered in healthcare settings.
Right. So once the UK IPC cell come up with the guidance and it is seen by the public health agencies in the respective 4 nations, there may be some toing and froing, some changes. Once it's been through that process, effectively, therefore, it becomes the guidance, unless someone else says something different about it and PHE need to align that with another body or another agency.
Correct.
Is that it? Right. Now that we've got to that position, do you think it would have been helpful for that to have been set out anywhere?
Well, I think, you know, clearly with hindsight and with people's views that can change over time, and, you know, it feels like it may be necessary to, but I think it's really important that this is well-established mechanisms for both working together collaboratively as organisations and thinking about things as we go forward. I would say that we did recognise this to some extent and have developed a memorandum of understanding with the department and NHS England. So I think we need to go wider and think about it as a 4 nations approach.
Can I turn, please, to some of the guidance? And we're not going to go through it all, Professor. But you have helpfully in your statement set out different tranches of time when guidance changed, and there were perhaps some of the more significant changes. That's not to belittle the other changes. January to March 2020, can I ask you this? By the time that COVID-19 was declassified, was there in fact enough FFP3 to supply all healthcare workers in patient-facing roles?
My understanding was that there were, I was never told the exact number at the time. I do know the number now in retrospect, but the role I had, I was told at the time, and I was told in the guidance that I wrote, I was involved in writing, and for the wider mask wearing and FFP3 wearing in the health system, that I shouldn't be considering guidance for what supply was available. I should be considering guidance.
That's a different
on what's
question.
There. But that's what but I think that's really important, because I did not know in March 2020 what the supply of masks were. That was not part of my role. And I think that was not part of the organisation, was not told at any time, and I don't recall anything saying at any time that we must change this guidance because there won't be enough FFP3 masks.
So you didn't know then whether there was or wasn't enough FFP3. Yeah, I think you said, but you now know.
Well, I know.
There or wasn't there?
Well, I know that there were in the order of 26 million FFP3 masks, and that there were more being purchased all the time. It then would depend on how much you used an FFP3 mask and whether you used it once per patient, which would mean 30 or 40 masks a day, or even up to 100 if you were doing lots of interactions, versus 1 per session, which could mean 2 or 3 masks a day. So it really would depend on the use of the masks and how they were used to.
Can I put it another way? You told us in due course there was a need to prioritise which AGPs and areas, hotspots, call it what you will, for FFP3. Doesn't it follow that they were prioritised for a reason because there wasn't enough FFP3 at that time?
I think they were prioritised to prioritise the greatest risk areas that were considered at the time to the protection that was available to protect people.
Can I ask you about the extent to which the lack of supply or supply difficulties affected the early guidance? And can we look on screen, please, at 398198_2. It's an IPC cell meeting from the 4th of March. Now, you're not in the cell, are you, Professor? I want to make that clear. But just to look through you, if I may, can we see the supply chain update as at the 4th of March? Can we highlight that? Thank you very much. And one of the contributors there is talking about noting there's a healthy supply of FFP3, but there is concern around demand for swabbing patients. Models being looked at is that 10,000 patients will be swabbed a day from next week. Someone else noted the supply chain are looking at releasing stock from the pandemic stockpile, but the models may not fit people's current usage. And this, another contributor said, noted the pragmatic approach may differ. For healthcare workers looking after patients who are confirmed, they should be the priority for wearing FFP3 rather than those in minimal short contact. I just want to understand what PHE's position is. Where is this pragmatism driving the guidance rather than the science, if I can put it like that?
Well, I think what you can see also is that on the line above is that it's about fit testing. So there's a degree of how things can be operationalised, I think, which is often called pragmatic in the NHS. So can you actually get out a whole new types of masks that all need to be fit tested with different people? And how do you prioritise the masks that people are used to wearing and are appropriate for individuals, recognising that there can be 10 different FFP3 masks, but only one is suitable for an individual, and how those are therefore prioritised for use. And I think, again, about prioritising it for where the highest risk is coming through at this point.
All right. Now, in fairness, as at the 4th of March, it's still an HSID. So we always need to keep that in mind, which may have slightly altered the way people are talking about these things. Come the 6th of March, though, there was updated guidance, and I'm at your paragraph 295, if it helps you, Professor. There was updated version of IPC guidance, and in short, the guidance advised that FFP3 for use by workers conducting AGPs or in contact with confirmed cases, and FRSMs should be used for close patient contact of a possible case. So that was where we were just before we went into lockdown, effectively. Is that right, that stayed the position then for most of 2020?
Well, I think actually the position changed in the sense that traditional infection prevention control is only used for where infections are suspected or confirmed. And actually what we did was we changed that to all patient contact required fluid-resistant surgical masks or any contact in areas that AGPs were being performed, not necessarily in confirmed. And then more widely in June, that all staff in hospitals wore fluid-resistant surgical masks to prevent the spread to each other and to patients.
OK, we'll come on to that. Can I ask you this, though? 6th of March, COVID is still an HSID. Why at that time were you requiring the use of FRSM unless carrying out an AGP when it was still classified as an HSID and therefore should have been FFP3 for at least another week?
Well, I think that, again, this was about operational. Well, I'm just reflecting. I just be clear that this is a moment in time. I don't recall the exact decision making. As I said, I wasn't sitting in the IPC cell. The components that I think would have been considered at that time are things like the whether individuals who are being possible cases, of which that is many individuals coming into hospital with a fever or with a cough or with a wide variety of symptoms, and the probability that they might have COVID-19, at which point at this stage in early March, it was still relatively low probability. So if you think that there are many thousands of people coming into the NHS each day through emergency departments and through elective procedures, and that actually it was still at this point for this guidance very rare that individuals were being detected as positive. And so it was to allow people to have some level of protection for those cases that might go on to develop or be COVID, but recognising that the vast majority were not.
Melody, can I just deal with the position at early April 2020 and perhaps then break for lunch? Professor, can I ask you, please, if you turn in your bundle to paragraph 308, and on the 2nd of April, on behalf of the UK IPC cell, PHE published updated COVID-19 guidance, and can we look, please, at INQ 348.325_4. this made a number of changes to IPC guidance, but it's the sessional use that I'd like to ask you about, please, Professor. Now, let me ask you this. Was this change to requiring sessional use of PPE driven in reality by lack of PPE or supply chain issues?
It was driven for two reasons. So one is that we had never used PPE in this way in the NHS before. So I've been working in the NHS for more than 20 years, but throughout my time here, and actually at any time before that, through people who've worked here for longer than me, we have never asked everyone in the NHS to wear some form of PPE all the time. It's always been a rare event, so maybe 1 in 20 patients at most that you would see in hospital would you wear personal protective equipment. And therefore, the supply chain was not resilient to this amount of PPE being used. The trade-off, therefore, in the views of a number of us who were developing this guidance, was to use things sessionally so that they would provide protection for both the wearer and the to others. It was was an effective way of mitigating this, which would be extraordinary use if we were taking it on and off for every patient. Right. That was discussed with Health and Safety Executive, who said that they would expect fluid-resistant surgical masks to last a few hours and FFP3 masks to last at least a day.
I follow that, Professor. Is the short answer yes, it was driven by?
So it was driven by extraordinary demand in an extraordinary setting that was was not preconceived pre the pandemic to be the way we would use personal protective equipment.
All right.
So this was an unprecedented piece of guidance.
All right. Aprons and gloves still single use, but respirators, surgical masks, eye protection, and the long sleeve disposable fluid gowns can be subject to single sessional use in various circumstances. Can I ask you this? How long would a session be?
I mean, it would vary. So we typically, when we're doing, so for example, a ward round, you would typically start your ward round and go to the end, but you might take a break if it was particularly long length of time. I suppose a bit like our day here today, it would never last less than 2 hours, a session at the same time. You'd be expected to work at least 2 hours, and frequently people would be expected to work 4 hours, often without a break or for a very short toilet break if necessary. Hospitals are very busy places, and we are required to see a lot of people in a short space of time. In some parts of the organisation that might be shorter, so if you were doing a very high intensity task that required a lot of concentration, you might break after half an hour to have a break. But then in other situations, like in some complex surgery, you might keep going for 12 hours. So I don't think it was allowing people to break down those sessions into how they worked rather than saying 1 hour, 2 hours, 3 hours. And again, that was based on the overarching evidence from HSC that these masks would be able to tolerate this.
Well, it goes on to say, as we can see there on page 5, it's on our screen, while generally considered good practice, there's no evidence to show that discarding disposable respirators, face masks or eye protection in between reduces the risk of infection transmission. Indeed, frequent handling of this equipment to discard and replace it could theoretically increase the risk of exposure. The rationale for recommending sessional use in certain circumstances is therefore to reduce the risk of inadvertent indirect transmission, as well as to facilitate delivery of efficient clinical care. And should it say, and also because we don't have enough at the moment?
Well, I don't think that was what we based the guidance on. As I said, when I was involved in writing this guidance, and this was probably the piece of guidance that I was involved in, because it was such a seismic shift from infection control guidance to say we'll only use it if somebody has a confirmed infection, to we'll use it to every interaction in the NHS that we're going to do from now on. And that required that this was one of the pieces of guidance that had robust discussion at the senior clinical group, as you can imagine, because of that seismic shift for the unprecedented moment that we were in. And I would say that that when I was involved in this, I was never told you must do this because there's not enough PPE, but it made sense that we tried to deliver it in an effective way. Again, I'll come back that if you are delivering care to 30 patients on a ward and you're going to see each one of them, And after each one of them, you have to take off all of this equipment, wash your hands, then go and find new equipment. That slows you down too. And so it was really to think about how we provide care to both protect patients and to protect healthcare workers.
Lady, would that be a convenient moment?
And I'm going to be incredibly generous and give an extra 2 minutes for the hour's lunch. Otherwise,
Thank you.
I might face a rebellion. 5 to 2.
Thank you very much.
All rise.